this case. This is in the coronal cut where you can see that it is going on either side, and this is the falx. So it is through the falx, through the cribriform, it is going down, and through the falx, it is going to the opposite side. So not seeing, going into the video because it will take more time. So just the pictures, the representative intraoperative pictures. We have done unilateral craniotomy. You see, bilateral craniotomy has its own disadvantages. Dealing with both olfactory tracts, dealing with both sides of the frontal lobe, that gives post-operative morbidity, a lot of morbidity. So you can go with a one-sided craniotomy. You are seeing the tumor, you can start removing the tumor. If you can reach to the base of the skull in the beginning, nothing like that. If you cannot, you can start devascularizing the tumor and start debulking, and ultimately you will reach to the base of the tumor. Now, once you have removed adequate tumor, you see the falx. This is the falx. You can cut the falx, and after cutting the falx, you can go across to the opposite side, can remove through the unilateral approach, cutting the falx and it can remove the bilateral. So this is how you are connecting the compartment from right to the left. If you see the falx, the dura folds, they are actually the corridors to go from one compartment to the other compartment. And dural folds has got the venous sinuses. So if you know the anatomy of venous sinuses, you can connect any compartment by just doing the skull base approaches. So what you need to see in the anterior region, the falx, the superior sagittal sinus is rudimentary. You have very, very small veins which are draining. You can always cut the falx. In the middle part, in the middle and the posterior part, you need to see that the inferior sagittal sinus is not dominant. If it is not, then you start cutting from below. If it is, then you can cut in the middle, and you can create the corridor to go to the opposite side, both in the middle and the posterior region. So this was the post-op scan of the same patient, where through the unilateral approach, there's very minimal local changes after the surgery, but good, otherwise overall good surgical outcome. So how can you connect the middle with the posterior fossa? So we all know that middle fossa, dura, reflection is different from the posterior and the anterior dural fossa. We have the two layers of the dura in the middle fossa, the meningeal and the periosteal layer. These two layers contain these 1, 2, 3 parts of the trigeminal nerve. And in the middle fossa, you have two reflections, this and this. And in between these two reflections of the dura, or the two parts of the dura, you have all three components of the trigeminal. And then it becomes the nerve, single nerve, and goes into the upper part of the CP angle, becoming the trigeminal nerve. So in the middle fossa, you have two parts of the dura, and when you go down, it becomes single dura. So when you are So this is the case, intraoperative pictures of various stages. You have done the temporal craniotomy, remove the zygomatic arch, it is good. If you don't want to, you can just flatten the base of the skull. Then you are seeing the middle meningeal artery. Middle meningeal artery coming out through the foramen spinosum. This is the landmark, which will tell you that this is the area where you will find the reflections of the dura, the endosteal and periosteal. Once you are here, you keep dissecting and keep creating the plane between the two parts of the dura. And since these are the approaches which are usually done for the trigeminal schwannoma, where it is going from middle to the posterior fossa. And in these cases, if you see, the petrous is already eaten up, and rest of the petrous ridge is exposed. This is the posterior aspect arcuate, this is the anterior side, and here the petrous is eaten up, and you can create the plane and remove whole of the petrous with a drill. And once it is removed, you see the tumor is there in front of you, and you can open the dura here. Keep opening the dura and keep going posterior, because here the dura, you are in the interdural space. So here you are extradural. But since both the dura, they are connecting here in the posterior, so you are intradural in the posterior aspect. So this is how you can connect. And here you find the superior petrosal sinus. If you feel that there is more medial extension, you can always cut the superior petrosal sinus. The way you are cutting the superior sagittal sinus in the anterior aspect, you can cut similarly coming from both the sides, the posterior and the anterior, and you can clip or coagulate the superior petrosal sinus and communicate the two compartments. So this is the pre-op, both middle and posterior fossa extension, and just by doing temporal craniotomy, we can remove the whole tumor. So this is what we saw just now, that the petrosal sinus is here. Your craniotomy is based here. It is not here. The craniotomy is based here. And when you are doing petrosectomy also, if it is tumor, it will give you the way. If it is not, then you have to do the complete petrosectomy. And you can remove you can cut the petrosal sinus if required, if the tumor is more anterior and more medial. So another thing is, how can you connect the pre-sigmoid with the retrosigmoid compartment? So this is a 40-year-old male who presented with facial numbness and profound hearing loss. When there is profound hearing loss, you can go translab. If there is hearing preserved, you can go retrolab. Here, there is extension of the tumor above the 7th, 8th nerve, going above, going along the tentorial edge. This is the posterior petrous. Here is the posterior petrous. So this you can remove right up to this part. It is easily can be removed through the retrosigmoid approach. But what about this part? So for these cases, you can combine. This is the part which will require some added approach. So you can take the similar incision what we take in the retrosigmoid approach, just curving it over the pinna. So that gives you the exposure for mastoidectomy, as well as from there you can take the fascia to cover the defect, what defect you get after the mastoidectomy. So this is the retrosigmoid craniotomy, and this is the area where you do the mastoidectomy, translab or retrolab, depending upon the hearing. So this is retrosigmoid part, dura exposed. This is cortical mastoidectomy. This is after cortical mastoidectomy. And this is the bone which is over the sigmoid sinus, can descleratize the sigmoid sinus by removing the bone. So this is sigmoid sinus. Here is the petrosal sinus. This is subtemporal dura. And here is the pre-sigmoid dura. So now this is pre-sigmoid dura, this is subtemporal, and this is sigmoid sinus. So there are two things. Sometimes you get very big sigmoid sinus. So there, in those conditions, it is very difficult to get this space. That is one limitation. If this is, then it is difficult to get the space and go into the tumor area. So what are the things you can do? You're opening the pre-sigmoid dura here. You can open the post-sigmoid dura here. If required, you can open the subtemporal dura here. This is a sigmoid sinus, this is a petrosal sinus, you can cut and connect. And there's no need to deal with this, there's no need to cut the sigmoid sinus, of course. And from inside, because dura is the door above, so from inside only you can connect without cutting the overlying sinus, you can connect the pre-sigmoid with the post-sigmoid compartment. This is post-operative scan of the same patient where we used both post and pre-sigmoid approach. This is wrongly labeled. This is left side. This is right side, but here it is left side. And this is another case where both the combined approach was done and removed the tumor. Anterior aspect of the brainstem. And last is supra and infratentorial compartment, that is suboccipital transtentorial. You can do in the prone position or lateral. Lateral is good because that gives you advantage of the gravity dependent retraction of the occipital lobe. The main thing is that you need to address superior sagittal sinus and transverse sinus. Very good craniotomy is very essential. If you land up into the sinuses, then the whole purpose of doing the craniotomy is lost. So all the sinuses, especially the medial aspect and the inferior aspect, they should be nicely, the dura should be reflected and you can expose it. Then suboccipital retraction, of course brain has to be relaxed. Then you see the sigmoid, the transverse sinus here and the straight sinus here. This is good, huge space which you are getting. You may not be lucky to get all the space all the time. This is transverse sinus lower down, this is straight sinus, this is sagittal sinus. So, and there are many sinuses here. So you may not be lucky that you will find this kind of space all the time. So you have to be careful from where you need to start opening. In this case, you can start opening from here to here, everywhere. But here in this case, where you have many sinuses, you need to optimize from where you will start opening. Just 2 minutes, 1 minute only. Sometimes you will be very lucky that you will get to see the medial margin. So your aim is to start from here and reach to the medial most margin of the free edge of the tent. So starting from the attached margin, you have to come to the free margin. And the moment you are opening the free margin, you are here, where you can address the pineal region tumors, means you are connecting the supratentorial compartment with the infratentorial compartment with the tentorial surface of the cerebellum. So it is very good approach, and it is good for all kind of pineal regions. You don't need to do the supracerebral approach. Only thing is you need to identify which part of the occipital lobe is dominant in terms of the occipital veins, not right and left. You may find very big occipital veins that can be very big hindrance, and you may find very big venous sinuses in the tent. It is not the supra or infra displacement of the deep veins. Deep veins, they are very nicely enwrapped in the arachnoid. The nature has given very good cover. You can't penetrate it unless you really want to bang into it. So suboccipital approach is ideal for every case. The only thing is you need to decide you'll go from right or the left based on the occipital vein dominance. So here, this is how you can open. You reach and you directly reach to the tumor site. This is a tumor which you see just after cutting there. You are there right in the pineal region. And there you can go, this is epidermoid. You can go intraventricular, third ventricle, thalamus, intraventricular, can reach right up to the aqueduct. So to conclude, all the compartments are interconnected. Of course, endoscopically easier, but you need to know where to go endoscopic, where to go transcranial, and you need to have the understanding of dural reflection and reflections and venous sinuses. Thank you.
Thank you, madam, for your wonderful talk. And the house is open for questions. We have total 8 minutes for the discussion, and now over to chairpersons for the comment.
Thank you to all the speakers, and if there are any questions, so yeah, please, Rupesh.
This question is to Dr. Suresh. I spoke on endoscopic CSF leak. Yeah. So you mentioned about you'll do a CSF manometry in cases of CSF rhinorrhea and then decide. But you see, when there is an active CSF rhinorrhea, your CSF manometry may not be accurate. So even if it is a high, the patient is actively leaking, it may show erroneously. So how that will help you in deciding whether, and doing a shunt within 3 days, I think it's a too, we can wait for some, medical management still works after the CSF rhinorrhea. So your thoughts on it? Reliability of CSF manometry.
It is low as expected when the CSF is actively leaking, CSF pressure will be low. So then we are doing endoscopic repair, going ahead with the repair, and we keep the drain, sir. So on third day, we'll measure the CSF again. So if it is high, then we are going for shunt, sir. Yes.
You will close the drain for lumbar drain and then measure.
Can you take a mic, please?
So for 3 days, so we drain, sir, continuously. On fourth day, we close the drain, and after 24 hours, we measure the pressure. If it is more than 20 centimeters, then we go ahead with shunt, and if it is less than that, then we will avoid shunt, sir.
Okay, so that means you don't consider medical management at all. It's directly you go for
For spontaneous leaks, sir.
Okay, maybe it's too much. I think we can still go for medical management. Majority of the time, the acetazolamide helps, and what we do is we wait for 3 weeks. and then we can decide on the shunt. Because within 3 days, I think it's too early. And the other thing you told, algorithm 2, you'll do a shunt first and then.
So it is a practice, not at our reviewed various literature, in which some of the papers suggested they are doing raised ICP, they are going ahead with the shunt first. Not since, so they will avoid endoscopic surgery. If there is any recurrence of, then they are endos.
On the same point, what we so what we practice is that on the day of surgery, on the day of endoscopic surgery, we do the pressure then there itself. If the pressure is high, in spite of having a leak, I do the shunt along with the repair. Otherwise, we wait, do a repeat LP a month or 2 months later. But if the pressure is high on table while the patient is having a leak, I always tend to put a shunt then and there itself. If the pressure is high, even with the leak, which means it is high. So I don't think we should be waiting. That's my point. That's my logic of doing that.
So you mean there is no role of lumbar drain? You said that the pressure is high, you will do a shunt. But if the pressure is high, it is said that if you put a lumbar drain and need for 5 days or so and give medical management once you have repaired also. So you drain it continuously and keep it for 5 days and then see if it is subsides, then it's fine. Otherwise, one might have to do a shunt.
No, the point is it might leak again if the pressure is persisting to be high even after the repair. That's the point.
Yes, sir, please. Is Deepak with us? Is he?
Yeah, this. Right,
Can
okay.
you
I
check
mean, this is actually for Deepak, and I just want to echo his opening statement. And I'm very strong proponent of what he says. We are doing extensive endonasal surgery nowadays, and when we say extended, and the amount of morbidity that we produce is never, and I'm repeating, never ever brought up by the same surgeon. He never discusses all those things because it's the ENT guy's problem. And the average encrustation takes 108 days as the median time to recover. That's international literature talking. The other, of course, the do's and don'ts are forever for a lot of things. And we don't know. So we are doing a mini craniotomy actually through the nose in the name of, in the garb of minimally invasive, in the garb of being sort of, no incision, cosmesis and all those things. So that's to be remembered. So you have to be judicious about all those things, and the amount of mucosal damage which nature has given us as a humidification process, as a process for prevention of very allergic substances and the pathogens to go into the respiratory tract is taken off. So we don't know in the long run, 25 years, how these patients are going to behave. So we are just in the zeal of showing off. We do these things. So we have to be judicious when you're picking up an extended endonasal approach, when it's definitely indicated like rhinopharyngium or something like that, which are totally localized, fine. But like meningiomas going the margins of excision, you're living behind the cuff of the dura, and it will going to recur very soon. I mean, very sure. So you have to be careful about that.
Yeah, I think
Absolutely,
point
sir. In
well
fact,
taken.
there's a talk in the next session by Ashish sir where he will be in one of the sessions talking about uninostril, because I requested him to do that. And sir would be knowing, we have been presenting our work at various forums about the uninostril approach that we follow at AIIMS Bhopal to respect the nasal anatomy. We always say it that because you don't feel the importance of it doesn't mean that it is not important. If nature has given something, it is for a reason, and we have to respect that. And that's why we promote the uninostril transseptal endoscopic approach. I remember Dr. Iswaran commented in Chennai when we were at the Asian Australasian meeting. He told specifically that it's the original transseptal approach which was done microscopically, and now we are just putting the endoscope. So yeah, that's a very, very important point that the youngsters need to learn. You've got an instrument doesn't mean that you're going to go everywhere, destroy the septum, destroy the turbinates. Please respect those.
Yeah, that's perfectly right. If I've done 2,000 pituitary tumors now, by now, most of my endoscopies are uninostril approaches. Up to 3 centimeters, I can go uninostril and remove it. No problem. I don't need assistance also, to be very honest. So you need to have that, the ability to do it.
Thank you.
Question to Dr. Anita, madam. You showed that the large meningioma of the posterior fossa, you did both pre-sigmoid and the tumor had come. You need to do a pre-sigmoid because once you start decompressing, the tumor itself will give more space because adding another exposure is going to take more time with additional mobility of till now. So do you really need pre-sigmoid in that, which is
Yeah, you're right that we actually started that we'll not open the dura from the posterior aspect behind, but making a small craniotomy behind the sigmoid is good because that gives you the area of mastectomy. Some landmarks are already visible to you. And as I said that many times the sigmoid is very big, you may not find good pre-sigmoid area to open the dura. So you have to make small post-sigmoid craniotomy, not as standard as the retrosigmoid craniotomy, which we do for the posterior fossa approach. And we started debulking it from the posterior side, but since it was going lower down, right up to the lower cranial nerves, then it was difficult. If it is up to the 8th nerve, it is fine that you can remove. But if it is going down to the medulla, to the retromedullary system, then it is difficult. Then you have to combine the approaches.
how long it took for you to do exposure time alone?
So retrosigmoid, we are very familiar. Pre-sigmoid, it took only 45 minutes to 1 hour.
Yeah, and the risk of morbidity of the facial nerve?
You have to be careful. Doing translab, you have to be careful about the facial canal and facial nerve preservation is has to be there. And of course, the main problem is CSF leak. So your cavity should be closed properly, and you can close the, if there is no hearing, you can always close the tympanic from the inside also.
I think in these such type of cases, the far lateral approach also has its own importance, and I think we should be ready to use that as well. So if there are no more questions, I think we can conclude this session. Thank you. Thank you.
Thank you all for your presence here today. Now, we begin our inaugural ceremony of the Skull Base course. After a break of 5 minutes. Thank you.
to do by a supraorbital or a keyhole or a mini-terminal keyhole. So talking about this supraorbital beautiful keyhole approach, so this is a minimally invasive approach, and not all the tumors, as I said, only small tumors where, small tumors. Can I not control this tumor? I want to run this, no? The video. Oh yes, I can do that. Thank you so much. Okay. So this was one such tumor, and you see the supraorbital approach was planned, and the position is an absolute paramount importance in these minimally invasive approaches, and needless to say that this is all under image guidance. So this is supine with head flexed on horseshoe and rotated contralaterally 30 degrees. I purposefully keep the head slightly flexed because to see the skull base, anterior skull base, it is easier to see when you are having the head in a flexed position as contrary while it is in an extended position. So this is, the incision is this, a straight linear incision. This is the craniotomy intended, and this incision is on the eyebrow, which is lateral to the supraciliary nerve, and this is of essential importance that this nerve should not get damaged, otherwise your whole purpose of the surgery is lost, because it gives a very, very irritating hyposthesia over the eyebrow if this nerve is damaged or cut. So this is essentially a cosmetic approach, and once you make a craniotomy and see the size of the craniotomy, you strip the fascia, and then you make a burr hole laterally, and then you do a 2 by 2 centimeter craniotomy, saving the dura. I don't think it's progressing. Chal nahi raha hai. So the rest of these steps are similar to what a conventional approach is. The beauty of this approach is that, I mean, it's a small keyhole incision, and this is very, very cosmetic, and healing times are less. It's not running. So the principles of the tumor removal, the meningioma removal, in fact, is the devascularization, decompression, and then dissection, keeping the, no, it's not working. So I won't be able to show the videos. So anyway, coming to the keyhole mini-terminal approach, I mean, these are some examples of the mini-terminal approach. I'm not able to control this from here. It is automatically moving from there. This is a post-op scan. This is about another olfactory groove meningioma operated by frontolateral approach, not a keyhole, but frontolateral approach, subfrontal. We went transsylvian as well as the subfrontal. It's a post-op CT scan. Patient had anosmia before. After the surgery, no chance of saving the olfaction, and we do the CT rendering to diagnose the position of the blood vessels, especially the anterior cerebral arteries in relation to the tumor, and this was found to be posterior superior, so that, I mean, it's a chance to save these, and so that we know it before the surgery that we are dealing with. Another olfactory groove meningioma dealt with by a frontolateral approach, post-op MRI at 2 years. And similar, this is a smallish olfactory groove meningioma, and this is the size of the craniotomy. Patient had anosmia and headache, and you see a lot of edema. There are several factors which determine your surgical plan, actually, because you see there is a lot of edema which is there in some of these secretory type of meningiomas. There you have to be very, very cautious about, especially with brain retraction, because with this edematous tissue, if you retract the brain, then the results after the surgery, they can be disastrous. So you have to choose an approach which is not dealing with the retraction of the frontal lobe. So that's why it's been done by subfrontal approach. Another giant olfactory groove meningioma, which is done through frontolateral unilateral approach. And this is another showing the position of the patient and the intended skin incision of the tumor. And this is a video. I don't think that I have time to show the video, but neither the videos are running on my call actually. They are. So this is an attempt to save the olfactory nerve. You see a large meningioma, but olfactory nerve, you can see it clearly. And it is an attempt. These nerves are very, very fragile. I mean, even a small amount of, if you touch it, I mean, the nerve is totally gone in a second. So you have to be very, very cautious. And unilateral olfaction, I mean, it's very difficult to save this. Whatever little olfaction that you can save is the contralateral side. That is, but now coming to the bifrontal approach, it's a beautiful approach, but this is maximally invasive. It requires your frontal sinus, I mean the venous sinus, to be cut and ligated, which may not be very well tolerated in some, especially in the adults. So you have to do a MR venogram before the surgery mandatorily in order to identify and study the venous anatomy over here. Some of the examples, pre-op and post-op, total removal of the tumor. So remember how much total you remove these tumors. These are notorious in coming back. I mean, 2 years, 3 years, 4 years, 6 years down the line, you find small little speck which keeps on growing after the surgery in the follow-up. So you have to be really very, very suspicious of the recurrence in these lesions, which occurs in quite a high percentage of the cases, even in grade 1 tumors. So this is what you can, I remember one Dr. Goel's talk about these tumors. These tumors you can never cure despite being these as grade 1. And this is what my experience has also been. So one such olfactory groove meningioma biocoronal approach. This is a 54-year-old female, and this is what it is. It looks like the position not very much extended. I need to look towards the base of the tumor, base of the skull, anterior cranial fossa, I mean, opening the dura, and then ligating the venous sinus.
So
and
we can
go into the tumor. Yes, I am finishing it up. Same principle, tumor revascularization with decompression, and then, thank you so much.
Now I would like to invite Dr. Ayadurai from Hyderabad to deliver his lecture on tuberculum cellular meningioma. Dr. Ayadurai.
Yeah, I'm here. Thank you, Adesh, for the opportunity. It's a wonderfully organized conference. So, tuberculum cellular meningioma, microscopic versus endoscopic, how to choose. I don't have any own series, like, and I have to do a lot of literary research, and then, like, I'm trying to put forward something useful. Okay, so here the tuberculum cell, like, which is seen as a ridge from the intracranial point of view, like, we have to keep everything in mind, like, cursor nahi aa raha hai, like, excuse me. So the bony prominence is like whatever we are seeing here is the limbus, prechiasmatic, chiasmatic sulcus, tuberculum cellae, and the optic canal, the optic strut. So these bones are not usually drilled when we go transcranially, but in case of an endonasal approach, like, we would see the the tuberculum cellae as an supracellular notch, and we have to drill or disconnect the way we do the extradural anterior cleidoctomy by deroofing the optic canal, drilling the strut, and like drilling the lesser wing of the phenoid. That is intracranial, but in the other way, like, we will have to drill the middle clinoid process, like the MOCR has to be completely exposed, and even with the even drill over the optic canal also medially. Like, these are the basic anatomical implications. The influential factors are the size of the tumor, bony anatomy, optic canal invasion, and then vascular encasement. So the suprasellar notch or the bony anatomy which were measured in a cadaveric study, like were measured with the lines drawn over the intraoptic canal and creating these angles, drawing the lines from various points. So what denotor is found was the angle less than 180 degree was least favorable for the transnasal approach, and that required extensive cranial extension, and it had a difficult reconstruction for also because the flap tends to fall back. But the lateral extension of the tumor, retrieving them out was easy. The type 2, which was most commonest, the angle was between 118 to 138 degree. They were intermediately favorable for endonasal approach. The head has to be kept in neutral, and reconstruction was better, and then lateral extension was also better. More than 138 degree, they were least, but then they were most favorable for the endonasal approaches. They are neutral to caudal flexion of the head was required, and it is best for the reconstruction, but lateral extension was found to be difficult, retrieving the lateral extension was found to be difficult. Another paper by Du-Sik Kong, they found that the line was drawn along from the limbus to the dorsum sellae. So anteriorly, if the tumor extension was, or if you see, the pneumosinus dilatans. Can I have a pointer, please? Excuse me. Can I have a pointer, please? So pneumosinus dilatans, if the tuberculum is going up into the cranium above more than 0.5 centimeters, and the tumor extending into the sella for more than 0.5 centimeters, they are most favorable for the endonasal approach. Then the size. In this, they have found the size-wise, up to less than 1.7 centimeters were found to be favorable for the endonasal approaches, but more than 17 millimeters or 1.7 centimeters were found to be less favorable, or they had difficulty in approaching it through transnasally, and then they were better approached through the transcranial approaches. So I would stick on to this slide for some time. So the size we had already discussed about, and the extension of the canal, they have made a scores of tuberculum sellae meningioma with this. So there are three scores, 0, 1, 2 for the optic canal invasion, and then 0, 1, 2 for the carotid artery encasement or the vascular encasement. So when we see very less invasion, the scores were 0. The scores, optic canal invasion was a little bit controversial, because all the time the transnasal approach was found to be favorable for the optic canal invasion, particularly medially. Most of the tuberculum sellae meningiomas had the medial optic canal invasion, very rarely lateral optic canal invasion. But the vascular invasion, the higher the score, or even 1 or even up to 180 degree also, it can be managed with the endonasal transnasal approaches, but more than 180 degree encasement of the vasculature and the involvement of the anterior cerebral artery and with its branches were difficult to retrieve it through the transnasal approaches. Size, of course, we had done it. So scores, excluding the optic canal invasion, if the score is more than 3, they were favorable for transcranial approaches. The International Tuberculum Sellae Meningioma study done by the American group, they found that in the lower part, from 93 to 2002, it was all cranial, 100%, and then it has started picking up, by 2019, it was reaching almost up to 60% of the cases were done by the transnasal approach. But they looked into several other factors too. The visual outcome was found to be far superior compared to the the transcranial approaches. So if you see the last line, the 308, among the 166 patients with the transcranial patients, like it remained the same, and 65 patients had worsened outcome. But the same numbers were like about 19 in the transnasal approaches. So visual outcome was found to be definitely superior with the transnasal approaches. But the transnasal approaches had high CSF leak rate, and then it is still persisting to be, even with the best of the experienced hands, also up to about 10%. So they had concluded the endoscopic excision for the resection of the tuberculum ciliary meningioma has been increased. The visual outcome is better, but the complication rates are high with the transnasal, particularly the CSF leak. So this was by Dan Kelly. For the supraorbital approaches, few points were given, like less than 135 degrees, minimal to no lateral extension beyond the ICA, presence of hyperosmotic tuberculum. Majority of the tumor above plenum, tuberculum angle more than 135 degrees, and the large tumor with lateral extension beyond supraclinical ICA, and no medial optic invasion were found to be transcranial favorable. So I'll just, this is one of the pneumosinus dilatans with a tumor. All the time, like when we go transnasally, like this much of optic canal deroofing has to be done for the mobility. When we dissect the tumor out, like if the bony edge is still persisting there, then it's going to kink against the bony canal, so we want to avoid that. I can't scroll it here. Okay, got it. So I just want to bring only one point here, so these are the structures, the microsurgical principles remain the same. Only thing we are going to use the monoshaft instruments, and it had to be the step by step, decompress, cut, bring the tumor into the field. So I just want to show this part, bringing how the medial wall optic canal invasion tumor can be retrieved out of this. We can see the optic nerve going inside, and it can be nicely preserved. Taken out, and then the complete excision is it is very much possible, and then we see the stalk inside the third nerve, and then the rest of the neurovascular structures which are all preserved. Post-op image. This is one other image which is showing the optic canal invasion. If you see carefully in the sagittal images, this is post-op scan with the ICG. That shows the superior hypophyseal is completely preserved. All the vasculatures to the optic chiasm and the nerve were well preserved, and then rest of the vasculature too. And optic nerve were also decompressed. Towards the left side, we see the tumor made impression. So this is a post-operative patient, post-operative scan, there was no evidence of any residue. So there's limited indication for a transnasal approach, it had to be wisely chosen, best outcome in properly chosen cases. Not all can fit in one. Just because we do the transnasal cases a lot, but avoid procedure-based approach. We should not push the patient for the sake of the procedure. And disease-based approach and individual confidence and comfort must be the deciding factor. If I'm confident with the transcranial approach for certain tumors, I would still have to choose the transcranial approaches. Patient's outcome is the paramount importance in any surgical procedure. With that, I thank the organizers for the opportunity. Thank you very much.
Thank you, sir. Next speaker is Professor Bernard Barlow. Sir is speaking about management of clinoidal meningioma.
Thank you, Chairpersons. I'd like to thank and congratulate Dr. Adesh for a wonderful conference. My talk for today is clinoidal meningiomas. So coming to clinoidal meningioma, this is the place where I work. So they are part of the sphenoid wing meningiomas, but they mostly occur more medially, so as compared to the lateral aspect, and they mostly involve the optic strut. So chances of visual problems are more. So this is the basic classification. They're around 15 to 20%. And depending upon the site, they do not follow any strict boundaries. They can go medially, laterally, superiorly, inferiorly. So basically they hover around the clinoid. So that's the most important thing. And I'll just talk about this because if the tumors are large, the FOTZ is also a very good approach. Normally you can tackle these by terional craniotomies, but the FOTZ helps you to get to the base as much as possible and devascularize and debulk that tumor. So basically coming to position now, this position is very, very important. You've got to have a little bit of extension so that we do not retract the brain. We do not, it's a big no-no, we do not retract the brain when you're removing meningiomas because there's already edema, and one has to prevent retraction as much as possible. So this is how the FOTZ is done. When we do it as a whole. We take out the frontal, the temporal, the orbital rim, the orbital roof, as well as the whole zygoma, because that is the best way to do it so that you get a good cosmetic reconstruction. Even the terional, sometimes you can get a depression frontally after the cut, and if the cut is too big, then and these are the cuts which are very, very important for the residents, where you have to know where to make the zygomatic cut, where to make the orbital rim cut, and also you have to disconnect the orbital roof, which has to come out in one piece. So it's very important. You've got to practice this in the cadaveric lab. And this is how it comes out as a whole. And this can be fixed beautifully after you drill the sphenoid wing completely. You can fix it with a good cosmetic result. So another important part of these surgeries are the extradural drilling of the clinoid as well as the intradural drilling, because you got to remove as much of the tumor as well as the dura, which is stuck at the base. So this is the extradural drilling, and this is the intradural drilling, which you have to see and identify the different anatomical parts, which involves removing of this part of the meningioma, which might go down into the optic canal, optic strut. So what we are doing here is we place a silicone paddy over the brain because you're doing deep drilling, and you have to expose sometimes even the Dowling's triangle there. Many tumors go towards the Dowling's triangle. So one has to excise all this dura which is involved by drilling intradurally as well as extradurally. So one has to know this technique, and you have to practice it in the cadaveric lab, which is very, very important. So I'll just share some experiences and videos. So here it's a complete removal of the dural sheath which is overlying the optic nerve as well as the ICA. So these are some tumors. I like to do the CT scan is very, very important for all these skull-based meningiomas, more than the MRI, because you know what is the bony amount you have to drill and excise and the hyperostotic bone. Angiogram is also important, especially if the tumors is going straight through if the vessels are going straight to the tumors. And this is how the position was given. So the excision starts with devascularization, and you got to keep getting oriented. Sometimes the tumors are very vascular, so no brain retraction whatsoever. So you just do a gradual debulking and identify the vessels around, and it's a gradual debulking. A lot of patience, it takes time, and a gradual delivering of this tumor. By devascularizing, you have to follow all the Ds: devascularization, debulking, dissection, and delivering. So the fluorescein angio helps you to get oriented with the vessels, which sometimes may go right through it. So you have to dissect on both sides of the vessels and then lay these vessels bare when removing these tumors, especially when they are around the clinoid. And then we reconstruct the dura, which is very, very important, because sometimes all your good work can be put to bad taste when CSF leak happens, and sometimes the patient can die of meningitis. So this is the patient. She had a recovery which was slow, but she went home after a month or so, because initially they came in a bad stage. This is another patient, similar. So they do not follow the boundaries of only clinoid, but the way to diagnose it, you'll see a dark spot within the tumor, which is the clinoid, and these tumors hover around the clinoid. And the technique remains the same. It's a gradual. Sometimes some may have a good plane, some may not. You have to create a plane by gradual dissection, and preferably do not use retractors to retract. As you decompress and devascularize, you can get a plane. So again, the vessels have to be dissected. Use the fluorescein angiogram, which shows you the feeders as well as the vessels. And then the basal part, and again I am telling it's the dural closure which is very, very important. So that is also the most important part of the surgery. This is post-op. Another case, this is going more towards the temporal fossa. The angiogram tells you exactly how much vascularity is there. And the initial exposure, most of these patients which are large, we do a FOTZ, which allows the brain to fall away and you don't have to retract anything and you are not struggling. So the FOTZ is a good approach. The smaller the tumor, then one can use a subfrontal unilateral approach or a pterional approach. But you have to judge accordingly, studying the CT scan as well as the MRI. And as far as I go, I think you can achieve a grade 1 max. You can't achieve a grade 0 in these skull-based tumors. So hemostasis is also an important part. You have to spend equal amount of time doing the hemostasis and reconstructing this base. So that's the most important. You can use fat, fascia, artificial substitutes only if you are running short of the natural substitutes. That's the post-op. So this is a case of bilateral lesions. So here we tackle the left side because the vision was involved on the left side initially. So go for the one which is bigger and causing visual loss. So open the sylvian here as much as possible. Do a gradual debulking. And then the procedure is the same once you get the plane. Here you'll have to drill the clinoid inside also as well as outside, and then remove the tumor which is going into the optic canal. But it has to be done piecemeal. One should not pull. Even if you see the capsule, it's a gradual delivery of the tumor, and then getting off the tumor which is in the optic canal and also into the temporal fossa. Some of these tumors can go into the cavernous sinus also. And that's the delivery of the tumor. So this one, we did it on the left side. After 2 months, we went on to the right side and did the same. But here we had to do, although the tumor was small, the intraosseous involvement was more in this. Here we are drilling the clinoid and then also had to drill the orbital fissure here and getting this tumor, which was dissecting it off the ICA as well. So patience is the game. You have to be patient, and so I've not hurried up this video because you have to be patient and as meticulous as ever. And proper hemostasis. So that's the post-op scan and that's the post-op MRI. So this is the last patient. Again, similar technique. So that's the post-op. Another patient, this is a smaller one. You can use a pterional craniotomy. And this is the post-op MRI. So the importance is, like when you operate on a meningioma, you feel like this, as if you have climbed the summit of the Himalayas, Mount Everest. But it's very important to know that you have to leave some stamina for you to see complications and also to do a good dural closure. You have complications like this which can happen, and you have to be ready for them mentally as well as physically. And it's also important that, you know, getting down the summit is more difficult than going up the summit. So you have to spend equal amount of time in closure. So position, very important, proper exposure, do not compromise on the craniotomies, and you have to be reconstructing the defects very, very meticulously. Thank you, and I want to invite you all for the neurotrauma, which we are doing in Goa, 8th to 10th August. Thank you very much.
Thank you for delivering a nice talk. Questions and suggestions are welcome from the audience side.
Sir, in all these videos, all the orators have shown, they are looking like the tumors are relatively not that much vascular. Means all these, in these sessions. But olfactory groove meningiomas and all these things, they are relatively more vascular, or?
No, it depends. That's why you do an angio.
All the videos,
we still
you
do an
just-
angio.
yeah.
So they are not that non-vascular. Okay, you're going to be ready with blood. Yeah. So technically, meningiomas, you know the vascularity, okay? And if it is very vascular, then it could be a hemangiopericytoma more than a meningioma, in my opinion. But the vascularity of meningioma, you can judge. You see the MRI, you can do the angiogram also, and it is easier to judge, but you have to be ready for blood loss. That's why.
So the role of any embolization preoperatively?
I personally don't do any embolization. They say ECA embolization if there are feeders and all those things, but personally I don't do any
No, sir.
embolization.
Means suppose we open the meningioma and it is very vascular. So that time we can go for a decision like, okay, I will go for embolization and then come back. Is that type of strategy is sometimes comes in the minds?
Not exactly. You can go in a second sitting also. It becomes much easier. If you find too much vascularity, you maintain the hemostasis, you do as much as possible, leave the capsule, and then go in again. You'll find it much easier because the vascularity decreases. We have done that also.
Thanks, sir.
Sir, very nice presentation. I have one question, sir.
Yeah, please.
That's such a big tumor you presented. Like when ICU will be in case 360 with bifurcation, you shown indocyanine green you are using. Are you using Doppler or what is your approach?
No Doppler. I use the angiogram, which is the ICG, but fluorescein is better. Fluorescein is real time. Okay, ICG
And
is a negative
how will
picture.
dissect, sir, from proximal to distal, distal to proximal, that in case part of the bifurcation?
Yeah, the distal to proximal is better. If you go proximal first, you'll rupture the ICA.
So
you go from the periphery. We go from the periphery and see the peripheral branches first. Don't go to the main ICA trunk. You'll end up in problem. Probably even have an ICA control if you feel that the ICA is
neck
fully
control,
covered.
sir. Okay, thank you, sir.
Thank you.
So with this we end this session. And shall we go for the lunch time? Yeah, we request you all to join for the lunch. Thank you.
Gagan? Gagan?
यहाँ तो चालू करके देख लो मैं वीडियो देखना है वीडियो स्कूल होता है कि नहीं देखना लैपटॉप पे आएगा वो आएगा ना
डे वन पे डे वन में तो सिर्फ पीपीटी है, दूसरा वाला डे वन नहीं है सर, फोल्डर नहीं आ रहा इधर। अभी नेक्स्ट टॉक है, सबसे पहला टॉक वो फोल्डर नेक्स्ट है मेरा। पहला संजय बिहारी सर है। लोड कर लो ना। वो वाले मैं देखूँ एक बार? यहाँ तो लैपटॉप में नहीं है।
no attempt.
Respected faculty members and delegates, we request you to join us back. We are starting shortly with the post-lunch session. In case you have just started your lunch, we welcome you to take a seat within the hall, have your lunch and listen to the deliberations. Respected faculty members and delegates, we request you to join us back. We are starting with the post-lunch session. It's a very interesting session on skull-base vascular neurosurgery.
Good afternoon, everyone. Good afternoon, everyone. So now we are starting with the post-lunch session, session 5, which is based on skull-base vascular surgery. May I call upon the moderator for this session, Dr. Khurshid Ansari. May I call upon the stage the honorary chairpersons for the session, Dr. Sandeep Sorte and Dr. Ashish Pathak. May I now call upon the first speaker for the post-lunch session, Dr. Matthew Abraham.
Dr. Matthew Abraham is going to talk on when vesicular top aneurysms require microsurgical clipping.
Surgical management of aneurysms of the basilar bifurcation. Okay. So we all know that around less than 15% of all intracranial aneurysms are from the posterior circulation, and of this, little more than half are from the basilar bifurcation. So we operate on basilar aneurysms when they are more complex lesions, when they are not easily accessible, and when there are aberrant vessels, and when there is availability of expertise. We all know that this may be the last preference when it comes to most vascular surgeons. There are basically two approaches are there, the subtemporal approach and the transylvian, and its combinations. So the transylvian when it is high, and the subtemporal when it is low. So for the transylvian exposure, the aneurysm has to be within this range, mid-cellular point and 1 centimeter above the posterior clinoid process. And for aneurysms below this line, a subtemporal or a half and half approach is better. And for very high aneurysms, even the transylvian may not be enough. You may have to sometimes go interventional or even sometimes transfer ventricular. So the most important thing is the preservation of the thalamoperforate vessels, which arise from the basilar trunk, from the proximal P1 and from the PCOM. I'm just going through the whole thing. I thought of the different barriers that go beyond the routine aneurysm surgery when it comes to tackling basilar top aneurysm. There are 12 possible barriers that will come in the way when you tackle a basilar aneurysm. The first one is the bony margins. Naturally, you go for an orbitozygomatic osteotomy, which gives you approximately 1.5 centimeter additional access. The next is to go for a more elaborate sylvian opening. I shall not go into the details of that. A very detailed sylvian opening will greatly, and the third one would be to divide the sphenoparietal sinus. This actually will move the temporal lobe away from your field and will greatly increase your access, maybe by around close to an additional centimeter. It is very safe to divide it at the proximal most end. The distal division of the vein is more dangerous. The next is the anti-reclinoid removal. These are all the barriers that come in the way between a basilar and your routine PCOM artery aneurysm. So this is a single piece clinoidectomy that I am doing. This is a fast procedure. It may be extradural, it may be intradural, it may be piecemeal, or it can be a single piece. Here a cut is made through the base, and the anti-reclinoid can be removed in a single piece. Naturally, the next step is to go to divide the distal dural ring. And as you divide the distal dural ring, the ICA and the optic nerve become free, and they can be moved or retracted. So this is the division of the distal dural ring, and naturally it comes after the removal of the clinoid. The next step is the uncus. The removal of the uncus greatly facilitates surgery for a basilar top. It does not produce any neuropsychological deficits for your information, and it brings the third nerve in the center of your field. This indicates that you are on the right path. If you find the third nerve in the center of your field, your direction and your approach is good for a basilar top aneurysm. You can see the aneurysm is already, since a giant aneurysm, in the background. The next step is the temporal pole. Removal of the temporal pole will facilitate a half and half approach. Even if you can move it extradurally out, finally the pole will come in your way. And if you divide the most proximal temporal branch of the MCA, the temporal pole is devascularized. Removal of a temporal pole may be useful. And then the tentorium. For low-lying aneurysms, division of the tentorium. This can be tailored. You can divide as much as you want. And only thing you have to preserve the cranial nerves sticking to it. So this facilitates a half and half approach. The next is the anterior choroidal artery. It tethers down, particularly when it is short and thick, it will tether down the ICA and your ICA mobilization will be affected. So if you can dissect the anterior choroidal artery up to its entry into the choroid fissure, it's a reasonably simple procedure, particularly after you have removed the uncus. Up to its entry into the choroid fissure, it will allow free mobilization of the ICA. Then comes the posterior clinoid process. There is a tenth of our barriers. The posterior clinoid process in a slightly deeper plane. Its main problem is it will sometimes interfere with the clip placed, and you can actually divide. A dural incision can be horizontal as Dorlang, or it can be vertical, and you have to retract the ICA medially. By that stage, you have already divided the distal dural ring, and the ICA is mobile. So you can radically drill off so that your clip will pass off. By this time, you have the space to pass your clip, a big clip or whatever clip you want, along with the applicator through the space. So it's basically a creation of space that is more important. So radical removal of the posterior clinoid becomes useful. The next in line is the PCOM, which can come in the way of your clipping. Sometimes the PCOM may not interfere, but very often division of the PCOM. The PCOM is better divided at its origin from the PCA. It should not be coagulated. It is better to apply 2 silver clips and then divide them. This greatly opens the space. And this is useful for when you are applying particularly fenestrated clips or during clip manipulation. So that is the division. And the 12th one is the oculomotor nerve. We know the transcavernous approach of Aliquist. So the third nerve can further be divided at its entry into the cavernous sinus. This will actually give you additional space when you approach a base nerve. So post-clipping, there are 7 points to be careful of. The aneurysm should be occluded, of course, that's compulsory. The parent artery should be patent. The efferent branches should be preserved. The perforating artery is most important, should not be affected. The adjacent arteries must all be patent, and there should not be any neck remnant, and blind spots must be clear. The most common problem is the residual aneurysm filling and thalamoperforator loss, particularly, and of P1 segment occlusion. I shall just briefly show a video where aneurysm is clipped and these aspects are checked. You can see this is the aneurysm. We have done all these steps in this patient except the zygomatic osteotomy, the orbitozygomatic osteotomy. A clip is being placed through the space where the clinoid would have been and where the posterior clinoid would have interfered. We have just passed it and placed. We find that a small portion on inspection of the aneurysmal neck is left. So this clip is being advanced. This tiny vessel is not a perforator, we have confirmed that. Now this aneurysm is being aspirated. This is a very important step because without which you can see here, carefully, you can see that this clip tip is going and catching the opposite P1. So this is not a great clipping. So we are going for a second clip which catches the fundus, misses the P1. Not catching any perforator. The first clip is removed. And you can see there is a residual neck there. This residual neck is now clipped with a second clip like this. So 2 clips have occluded this aneurysm fully. So it's just all the 7 points that I have spoken of have come in these 2 steps. Thank you.
Thank you for finishing in time. Any questions, please? Yes?
ligating and cutting the posterior communicating artery,
Yeah.
because that's not a very common step that we employ.
Yeah,
I
it's
mean,
not a
what-
common step. The PCA,
What is the clinical effect of that?
it will not have any clinical effect. The PCA, the PCOM can be cut at its junction with the PCA in a safe manner. If you occlude it at the other end, it will produce deficits. Mostly at the PCA, you can occlude it without coagulation. I must have divided in around 30 to 35.
Sigmoid sinus coming to the internal jugular. This is the ICA here. So the approach is here. ICA is right in front. So very difficult approaches, but we have some approaches designed around the sigmoid, sinus. So coming again, so you have to understand the anatomy of the temporal bone. Temporal bone is the very critical bone for middle fossa, and even two approaches to the front of the brainstem. So if you see here, so the middle, this ridge of the temporal bone is very important, and it has four main structures, if you understand. Of course, main is the internal carotid artery, then we have the eustachian tube, then we have one nerve, and which is GSPN, and another is the eustachian tube, and the muscle is tensor tympani. So just remember four structures, one nerve, one muscle, one tube, and one artery. So sphenoid, this we have seen in the morning session also. Just to revise, this is the lingual process here. So this is the lingual process from where petrolingual ligament is attached, which is the entry of the ICA into the cavernous segment. Before that, it is the petrosal segment. From here, it enters and becomes the cavernous segment of the ICA. These are posterior clinoid here. So this is the lateral view of the temporal bone. Not many vital structures here, but the mainly very protruding bone is the mastoid process. So we have transmastoid approaches through this. This is the top view. This is the petrosal surface here. This is the temporal surface, and this is the petrosal surface, which is the ICA, which is part of the posterior fossa. So this is the coming to the lateral aspect. So the approaches basically you can have from nasal to the center of the middle skull base, which are from medial to lateral. But then if you are coming from supracranial, it is mostly from lateral to the medial. So just if you see. So this is from the top. Here's the top view of the dural architecture. You can see all the cranial nerves here. This is the third cranial, fourth. This is a fifth cranial nerve. So fifth cranial nerve is the largest cranial nerve, and if it is the main cranial nerve when you are encountering these approaches. So this is here we have removed the dura and the covering around the fifth nerve. Now you can see fifth nerve, V1, V2, V3, and you can have impression of the ICA. This is the third nerve here. So if you see, we have removed part of the clinoid. This is the proximal and the distal dural rings, which you were seeing in the lectures. So many times, young neurosurgeons, they don't understand what is proximal ring, what is distal ring, what is carotid collar. These things can be difficult to understand, but if you do dissection and study these 3D pictures, it is relatively easy to understand. Of course, then you can see this is the petrolingual ligament here. So this is the petrous part of the ICA, which is in the middle fossa floor. This is the petrolingual. Then it is becoming here cavernous ICA. And this is the inferior-lateral trunk, which is supplying the lateral cavernous wall here. So this trigeminal has been reflected interiorly just to show this structure. And this is third nerve. So this is with all the, now we have removed, just to show the different triangular areas which are the related to the middle cranial fossa here. So this is the top view. Here you see the inferior hypophyseal, which is supplying the pituitary gland. This is again the inferior lateral trunk. Then we have the meningohypophyseal branches, which is going to the dorsal clival dura here. And this is with the venous injection. So this is the clival branches. So just to subtemporal approach, how the stepwise how to unlock, you just take the incision as per your preference. Superficial temporal, fascia removed, muscle, bone, burr hole, then you make a small craniotomy. The dura is not intact. Here you can see the intact dura. So just start lifting the dura. The first structure which you need to unlock is this middle meningeal artery. So once you remove it, then you can get a very, then you can do the anterior unlocking here. So you can peel off more dura, Then you can do the posteriorly also dura can be peeled off, and you can have the whole panoramic view of the middle cranial fossa. If you see, there's a third nerve here, V1, V2, and V3. And the GSPN and impression of the ICA is visible. This is the middle meningeal here. So this gives you a very, extensive view of this area. Of course, depending on pathology, you can modify this approach, then go more closer and remove part of the bone. Then this is a close-up here. This is the internal acoustic matters. We have the GSPN here. Then we have the deep petrosal also going, which joins and form the median nerve, which I'll show you in the endoscopic approaches also. This is the lesser petrosal here, and this is the cauda tympani. So these are the middle ear structures. So all these nerves, they can be dissected. This is a little close-up view. So if you see here, this is again the dura with the middle fossa. Here we have partially removed from the geniculate ganglion. So here in this picture you can appreciate this is the GSPN, this is the carotid in the petrous region. Then we have the vestibular structure, this is internal acoustic matters, and we have removed this petrous apex just to show the parts of the posterior fossa. So these are the different approaches which can be modified according to the requirement. So this is another deep view of into the, you can see 6th nerve coming here, 4th nerve, this is the 5th nerve. So this is pre-sigmoid approaches, transmastoid approaches, not, maybe this is not to today's this lecture, but this can be modified. This is a facial nerve here, this is external carotid, and you can see the internal carotid. This is the facial canal here. So different approaches, all these approaches around the internal carotid, around the facial nerve to reach the areas anterior to the brainstem or the middle part of the skull base. And this is again a beautiful picture, but little out of focus. So I'll skip to this one. Here you can see all the cranial nerves. They have been dissected. You can see the vestibule hanging like this. And this is the 5th nerve here. So in short, now coming to the middle cranial, to the transcavernous approaches, you know the steps. Now this is the sphenoid sinus with the midline septa here. You can see OCR. And here you can see tuberculum very beautifully. And this is the planum here. So again, after the bone removal, you see a lot of venous injection. This is again, now this is the median nerve. So median nerve earlier I showed is formed by joining of the deep petrosal and the GSPN. They join in some near the foramen lacerum and come out and come to this sphenopalatine ganglion. So median nerve on the opposite side, fully both sides you can see here very beautifully. So this is the dorsal clival artery here, which is supplying the clival dura. And in petroclival lesions or the lesions here can be the main source of the blood supply. So this is inferior hypophyseal, again supplying the posterior part of the pituitary gland. And this is the stalk here. And if you see the stalk, with this is the branches of the superior hypophyseal. Superior hypophyseal are mainly branches from the supraclinoid. They can be multiple, from 2 to 10 branches, and they are very critical to preserve the function of the pituitary and the hypothalamus. Inferior hypothalamus, you can sacrifice sometime, but if you see here is a beautifully, all the branches of the superior hypophyseal. And we have in the background, you see anterior choroidal and PCOM also. So here you see, this is the third nerve which is entering here in the oculomotor triangle here. So we have just deflected this band of the ICA. Just to show the anatomy, practically may not be possible, but sometimes the lesion can give you this space. This is the 6th nerve which is entering the cavernous sinus. This is the petrosphenoid ligament. So here, just to show that this is just, we have removed some part of the dura from here, then the anterior clinoid has been removed. So here you can see the lateral wall of the cavernous sinus. So with the endoscopic and all the extended, depending upon, this is also this area, this is part of the temporal lobe here. So with this, you can see whole of the skull base from the endoscopic perspective. You can see this is the V1 here, V2, and they, depending upon the space here, you can approach some lesions which are coming from here to the middle, from middle skull base to the nasal cavity. So with this, I think, thank you.
3D anatomy
of middle cranial fossa is very well covered. The next topic is anterior clinoid and anterior cavernous sinus by Dr. Ashish Suri.
Good afternoon. I thank the Skull-Based Surgery Society of India, the interim meeting, and special thanks to Adesh. He wanted me to speak on this anterior clinoid and process. I said it's a bit longish, but we'll try to reduce and try to run through. चल रहा है? ठीक. ठीक. Thank you so much. We all know that this pointer कैसे चलता है इससे? Okay. These are the anterior triangles of the cavernous sinus, the anteromedial, the lens, the important ones, the Hakuba, and the Parkinson's. That's the approach, and these are the two axis triangles. This is where I'll be focusing on anterior clinoid process, and there's a ligament which is covering, which is the meningoorbital band or the meningoorbital process. You have to expose the anterior cavernous sinus if you exposing the main idea is you have to drill not the ring of the pyramid, but the face of the pyramid, so that you expose the optic nerve. This is a small cadaver demonstration. Meningoorbital band is cut. You can cut it with the scissors, there's several methods, or you can cut it with 11 number or 15 number blade. Take off the lateral wall of the superior orbital fissure. Then expand the opening of the anterior cavernous sinus. That is the orbital roof. That is the V2 here. That is V3 here. But we don't need V3, but V2 is important. The moment you expose the V2 until the middle meningeal, no need to take off the middle meningeal also. Then as you start seeing the tip of the clinoid, that is very important. That's the fourth nerve. That is the third nerve. That is the V1. It's very important. If you want to drill this as the face of the pyramid, you must see the tip and you must feel the tip. Must make sure that there is no middle clinoid process. And then you drill that, and that is the cavernous sinus with the Dolling's part of the ICA, and that is the optic canal. That is nicely seen. The last bit can be dissected out like a shell. That is the optic nerve, which is deroofed. Medial to that will become the sphenoid sinus, so one should not be drilling that. And this is, I'll skip this because this is posterior cavernous sinus. Then intradural, this is the cut I usually make, a semilunar with a cut which goes down till the falciform ligament. Open the cilium fissure widely. And then there are two approaches. One is the optico-carotid corridor. This is optico-carotid corridor. This is the falciform ligament. Another is the carotid oculomotor corridor. That is the opposite side optic nerve. So if you see, this is small. This is a small optico-carotid corridor. The moment you cut the falciform ligament, it becomes bigger. And just go, and that is the corridor between the third nerve and the optic and the carotid. That is the pretemporal. So you have two corridors here, and you can widen these corridors by opening the Hakuba's triangle and by opening the Dollens triangle. That is how we are opening the falciform ligament and the distal dural ring. That is the distal dural ring is open. Most of the times, the proximal dural ring is not required. Proximal dural ring opening is difficult, and you may require in some complex aneurysms. I'll skip the posterior cavernous sinus. In this paper, this was written by Manjul, and with a quantitative analysis, we found that extradural clinoidectomy had 2.5 to area and volume than intradural. Both deroofed the optic nerve to the same extent, but extradural exposes the proximal and distal dural rings, while the intradural only exposes the distal dural ring. And these are the several methods which I was talking about, how to cut the meningoorbital band. So I feel that ACP is a very important landmark, and actually you can take a spectrum of lesions: extradural cavernous hemangiomas, angiofibromas, intradural supraorbital fissures, schwannomas, intradural middle clinoid meningiomas, giant invasive pituitary adenomas, craniopharyngiomas, IC and basilar aneurysms. Some examples: this is a complex ICA paraclinoidal parophthalmic aneurysm, and the temporal base is taken off. That is the B2. I'll scroll through the videos that because they are too long, some of them are long. Then you take off the base of the ACP, and you must feel the tip. That is important. Feeling the tip of the ACP is important. Must exclude a middle clinoid process. Then drill over the face of the pyramid. And then you have the optic nerve and the Dowling triangle. Then we open this parallel to the Swillen fissure, and we are on the falciform ligament, and the wide open of the Swillen fissure like that, and then opening the falciform ligament. When you're opening the falciform ligament, and then the distal part of it becomes distal dural ring. That is the aneurysm. I'll just roll through because there are too many pathologies. And that is the distal dural ring being divided. Here, we realize that we don't need the proximal dural ring. The neck was there. Temporary application, water bath coagulation. Always coagulate and make the aneurysm clippable, rather than trying to clip a complex aneurysm in one go. So this was done, and I'll just roll this through. Then another one, this is another complex one in which we've done an ACP drilling already. And this helps actually to put us, here we dissected the proximal dural ring as well, aspirated, and we have a clip at the Dowling's triangle, and we can reconstruct this aneurysm. So exposure of the ACP helps here. Another one, this was an SAH with a broad neck complex aneurysm, and we've taken, I'll just pause this, and we were opening the meningo-orbital band, drilling the ACP. The second part of the video was done later. And then this was SAH, grade 4, patient was grade 3, Hunt and Hess. And that is the falciform ligament, and that is the distal dural ring. And the moment we start dissecting the aneurysm ruptures, that is another reason why I do not prescribe. Yeah. You said something? Okay, sorry. Okay. I'll just go back. Yeah, sorry. So here, I'm just opening the falciform ligament. It was blank for a while or a long while? Short while, thank you. So while I was doing this, the aneurysm ruptured actually. And that is why I actually follow my teacher, Professor Dolenz, that in all these complex aneurysms do not have an intradural drilling. Always, this is only meant for incidental aneurysms and small hypophyseal aneurysms. And then I just packed it, put a cotton patty there, dissected a distal dural ring, and clipped it. And then I found that despite my clipping, the aneurysm was calcified. So I had a tough time putting those clips. And then I realized that there was another dome behind that. So then we started dissecting the proximal dural ring. Here, this is important. How to dissect the proximal. You need the glue sometimes, and you have to be slow there, patient. You dissect the aneurysm medially and laterally, dissect it off the ICA. These aneurysm partly going into the cavernous sinus, and then you can actually, so this was the part of the aneurysm was less calcified, so we could clip that properly. And because I realized the clipping time was a bit longish, so I did an STMCA bypass. I'll skip. The patient was fine. Then complex basilar aneurysm, again ACP drill. This is the typical 3T approach of Dolenz, in which you do an OZ approach, sometimes an FTOZ, anterior cavernous sinus exposure. That is again the tip of the ACP, extradural clinoidectomy. Here I'm widening the Hakuba's triangle and the Dolenz triangle both. The previous cases, it was only the Dolenz triangle. And then this is if you see, this is the opticocarotid cistern, and that is widened opticocarotid cistern. I can see, and then I go temporopolar. I go lateral to the carotid, between the carotid and the third nerve. I widen the oculomotor nerve entry by cutting this oculomotor trigone there. Yeah, I've cut this oculomotor trigone there, and then I can clip, yeah, this is cutting of the oculomotor trigone. You can give another 7-8 millimeters after cutting that, and then again, temporary clip. I won't go into the clipping portions. My lecture is on ACP only. So craniopharyngiomas, midline, I only do endoscopic, but in this was calcified, infiltrating in the hypothalamus. In all the craniopharyngiomas, I always advocate an ACP drilling extradurally. It helps. I'll tell you the reason why. In normal trional craniotomy, you can only do a transsylvian, but your access is either lamina terminalis or opticocarotid cistern. But the problem is, in craniopharyngiomas, most of the time, the opticocarotid cistern is very narrow. If you see, this is a very narrow opticocarotid cistern, right? So if you have an ACP drilling, you actually nearly double or 3 times the size. You actually widen it, and it is big now. You can just decompress, you can use your sonopet and excise it, decompress, and you can actually take off right from the diaphragma, and you can use the Kivo to see the last bit that was left. And you can actually see the stalk entry into the hypothalamus. Tuberculum cell meningiomas, I'll just run through a bit of it. Again, ACP drilling. I always do an extradural ACP drilling. It helps you to identify the carotid. There was a question last session. What do you do in middle? I always open the cilium fissure, identify the MCA, trace it down to the ICA. I think I'll just rush up fast and then decompress. I already have the Dolan's triangle with me, so I am safe all the time. Here, the only 2 important things. ICA, you'll never injure if you are in the right plane and you are in layers. What you'll injure is the choroidal artery. Patient will become hemiplegic because of the choroidal artery if you damage it or you make it put into vasospasm. Pulmonary compartment with giant pituitary adenomas, I'll skip it. Lateral wall extension, the access is through the Parkinson's triangle. Superior wall extension, this is where the third nerve mobilization is required. Cavernous sinus hemangiomas, here ACP removal is not required because it is usually bulging. It is, I would do it in the end at the anterior portion of the tumors. The angiofibromas, we do a lot with ENT surgeons, the Dosky's 3Bs. So to conclude, ACP and anterior cavernous sinus, this is my algorithm. So if you're doing extradural cavernous hemangiomas and angiofibromas, it really helps this removal of the anteroclarinodectomy extradurally, early identification of extradural ICA, 2nd, 3rd, 4th, 5th, 6th cranial nerves. If you're doing an intradural tumor, especially superior orbital fissure schwannoma, you can actually define the fascicle of the 5th nerve which is arising from. Thirdly, the most important, I think intradural tumors, it widens the opticocarotid corridor using the Dolan's triangle, especially in IC aneurysms of ophthalmic, middle clinoidal meningiomas, and widen the carotid oculomotor corridor using the Hakuba triangle, especially in the basilar aneurysms, and pituitary adenomas, which are not resectable by endoscopy, which have a superior wall extension. Thank you.
Any question from the audience? Okay, so excellent presentation, sir. Our next topic is choosing the correct approach for the lesions in the impedent cranial fossa, and the speaker is Dr. Raghvendra from the Chennai.
Good afternoon, everyone. Most respected seniors and colleagues, I thank the organizing team, especially Dr. Adesh, for giving me this opportunity. Today, this is the various approaches which can, and a respectful homage to one of the great neurosurgeons, made skull-based surgery easy, and this is the place where I work, Madras Medical College, and come here. So we all know right from the morning, skull-based lesions, they have a steep learning curve to approach, they are deep-seated, more often in case the critical neurovascular structures, they are in the midline, close to the midline, and on more occasions, the lesions have grown up large enough, and brain doesn't need to, like to be retracted, and it should be minimized as much as possible. Can I have a pointer, please? Okay. So these are the traditional various approaches which has been designed, and if you look at all of them medially go and land in the, these approaches, and all of them go to that particular point where Ashish Suri and the previous 3D anatomy has shown, to that middle cranial fossa, and can be used for lesions which are in the infratentorial compartment in the superior part of the brainstem, almost midpoint of the Fontaine region. And depending on these and the lesions and the locations, you can choose the approach. So initially in my career, for first 9 years, I've done 55 cases. Most of them I use the pterional approaches, and sometimes I use the combined approaches like the FTOZ, the transpetrosal, pre-sigmoid combined with cetrosigmoid, and the subtemporal approaches, various approaches depending on the lesion, which I thought would be easier to approach. And these are some of the examples. This is the clinoidal meningioma, which we had done using the Transylvian approach with the pterional craniotomy. And that is the lesion where the patient developed a cardiac nucleus infarct and had a hemiplegia initially, which recovered to do an independent lifestyle. This is another skull-based meningioma in the middle cranial fossa, which again I used the anterior subtemporal approach combined with the ACP drilling, and then this was done, a total excision was done, the patient was fine. This is another case where initially I thought it could be a schwannoma, meningioma. It turned out to be a schwannoma. They again used a combined approach of this anterior subtemporal with the Transylvian, and it was a long surgery extending into the posterior fossa. There was a rent in the tentorium through which it was extending into the posterior fossa, and this was the lesion. Total excision was done. The patient was fine and developed a sixth nerve palsy in the postoperative period, and this was the incision which I was using earlier in the large craniotomies. And after that, going through this FTO is that a half and half approaches and various other approaches by Sanjay Bihari sir, and this HEROES approach, where you go to the combined pterional anterior temporal approach and this Pavel approach, pterional approach to distal basilar via the external lateral corridor. That changed my approach, and in the later part of this recent years, done 51 cases, and the pure pterional has come down, and more often I'm combining with the anterior subtemporal, sometimes the temporal polar approach, so that basically the half and half approach. This is one of the example of the cases. You can see that is located in the slightly extending into the posterior fossa up to the upper part of the pons, and I took the half and half approach without much of the bone work, drilling work, and we could achieve a total excision in this patient. This is another case where a large lesion is again extending slightly into the posterior fossa. All these lesions are mostly in the infratentorial. Although they are presenting within the middle cranial fossa, they are below the tent, and the splitting of the tent combined with this half and half approach will give easy access to these lesions, and this lesion was their total excision, and an anteroclinoid process drilling was done. This is another case where, so diaphragmocellular meningioma, again you can see it is extending into the anterior part of the brainstem up to the upper part of the clivus. Again we can take the half and half for the Pavel approach and go ahead with the total excision. So the key here is, this is the postoperative image of that particular patient. I can see the basilar artery and other things, and a tentorial split would give wider access to the inferior most part of the tumor. It is there. This is another case where we had done, that is the arterial encasement. This is again extending here. This is again a total excision. This is done. So this is one of the cases where you can see this again is extending into the cerebral peduncle and going deep almost at the midbrain pontomedullary junction, where again the half and half approach was taken. The key is to do a wide split Cillian fissure so that there is the kinking of the middle cerebral artery is avoided, and based on the location you can use the temporal polar or the anterior subtemporal approach, and when it is combined with the tentorial split at the right position, total excision can be achieved. This is one of the cases where you can see this patient had been on follow-up for almost 8 years within a different hospital and landed up to us with a hemiparesis, the lesion crossing the midline, and the basilar artery is there, is encased within the tumor, and this was the coronal image where you can see it is again extending up to almost the upper pontine region in the posterior fossa. And nowadays, instead of, I use the standard pterional incision for all these exposures, and if you want to go more proximally, the neck is slightly flexed, and more distally, there is an extension component is done, and a standard pterional craniotomy is done, and this is one of the videos for what is. So there you can see the lesion, tentorium is separated, and there comes the fourth cranial nerve, which will be separated. This is the third cranial nerve, the carotid. There is a wide Cillian fissure split, and that is the fourth cranial nerve that is early identified. Slowly the third cranial nerve is separated. This is the third cranial nerve that is getting separated from the tumor. And there, looking at the inferior, whether the inferior most part of the tumor can be reached or not, that I decided very early itself. If it is not, then we'll go for a subtotal or a near total excision. So that is the first sign of the basilar artery. And I do debulking both lateral to the third cranial nerve and the medial to the third cranial nerve. Slowly the debulking is processed. And there you can see this is the basilar, the superior cerebellar artery and the posterior cerebral artery. It's coming, that is within the arachnoid plane, the tumor is getting separated. Because of the wide split Sylvian fissure, the brain retraction is minimal, and it is also aided by the tentorial split. So that is the superior cerebellar and the PCA complex. Slowly it is getting separated, and that is the basilar apex, and that is the tumor on the other side of the, but that is the brainstem, opposite brainstem, that is the opposite side, third cranial nerve with the arachnoid intact. This side the tumor has been removed, have to take it from the other side. So it is slowly being dissected away from the basilar artery, the opposite side tumor, that is the opposite third cranial nerve. This is after total excision. So that is after excision, that the basilar with the bifurcation, the opposite third cranial nerve, and that is the opposite superior cerebellar with the brainstem, and the total excision has been achieved. And this was the postoperative image. Patient had a stormy postoperative period, was with us for almost 6 weeks with tracheostomy, and then slowly she recovered. Now with the deficit. So these approaches are not without complications also. This is one of the early patients which I showed, developed the perforator was, I think, got injured and developed a hemiplegia and then later recovered. So half and half approach I'm taking in the recent times because of the familiarity of the structures that we encounter, and it is easier to protect and expect the critical structures where it comes. The retraction is less when the Sylvian fissure is widely split, particularly when there is a correct tentorial split which can be added to this. And nowadays I do it with a standard pterional incision. So neuroanatomy, as we all know, is an immense educational challenge, and the gold standard is cadaveric dissection, as we have seen yesterday. And thank you so much. This is my team. Thank you so much.
Thank you, sir. The next lecture is by Dr. Ashish Patnaik, extradural anterior petrosectomy.
Okay, good afternoon, everybody. First of all, thanks to the Adesh and Dr. Amit for giving this opportunity to present this very good, interesting this talk on anterior petrostomy and access to posterior fossa by middle cranial fossa. First of all, so this talk will be more for the young neurosurgeons and residents. So as we know, the anterior petrostomy and access to posterior fossa was popularized by Kawase in the year 1985 as extradural subtemporal anterior petrosal approach, which was later modified for extended Kawase approach or partial anterior petrosal approach or intradural anterior petrostomy. But this technique described by Kawase in 1985 has tested the time, and this is now being done on a regular basis. So as you know, the triangle for the Kawase or the quadrangle for the Kawase is bounded by the V3 division of the trigeminal nerve, on anteriorly, medially by the GSPN or greater cerebral petrosal nerve, posteriorly by the arcuate eminence, and medially by the petrous rees. But actually this, when you see the 3D image, or it's a 2D image, but you see the 3D part, actually this quadrangle is actually a pyramid or a rhomboid. The apex is formed by the petrous apex, and there is one side is a superior petrosal sinus, inferior boundary is formed by the inferior petrosal sinus, and the medial side, lateral side is formed by the GSPN. So what are the indications for this anterior petrostomy and access to the posterior fossa, middle fossa, the internal indications like meningioma, petrocula meningiomas, schwannomas like trigeminal schwannomas, posterior aneurysm like basilar top or basilar artery aneurysms, epidermis, brainstem cavernous, hemangioblastomas, and some rare extradural tumors like chondrosarcoma, chordomas. So this is a anatomy which shows, this is a cadaveric study. Basically, there is an angle between arcuate eminence and between the GSPN. This obtuse angle is divided by a line, imaginary line, which actually shows the internal acoustic canal, the middle line. So now you can see the angle is bisected by the internal acoustic canal. Now there is an important critical structure between the IAC and the GSPN, that is the cochlea, and we have to be very careful while drilling the anterior part. Now this bisection divides your rhomboid into two parts. One is premeatal and is postmeatal. For all practical purposes, the premeatal part is almost enough for drill for all our indications. But sometimes some proponents also, they are advising for the postmeatal drilling, that is behind the IAC. Which one? So this is the cochlea position, this is GSPN, this is the arcuate eminence, and this is the bisected line. So this is the next picture shows after the bone has been removed, you can see GSPN lies over the internal carotid artery, and the cochlea you can see are this thing. Now this is the bone which has been removed and which gives exposure to anterior upper part of the petrous series in front of the IAC, upper and middle part of clivus and lateral pontine lesions. So this approach is applicable for this type of lesions. So this is a very important thing, very important, you can see for the young neurosurgeons to understand. This is the dura, temporal dura coming here. This is the posterior fossa dura coming here. And at the in the junction lies the superior petrosal sinus. And these two dural folds, the joint continuous tentorium. This is the free edge of tentorium. So what you do in the approach is cut this bone first, then you cut the dura. Then you cut the posterior fossa dura, then you coagulate and cut the SPS or suprapetal sinus, and then cut the tentorium. Now all these procedures will create a big corridor from your middle fossa to the posterior fossa, dealing with the tumors here. So this is your fusion of the compartments, or in the morning, Anita madam has told already, the connecting two compartments, how to approach complex lesions. So this is that picture shows what is the course of the middle internal carotid artery in relation to the petrous apex. So operative steps, first is frontotemporal craniotomy with zygomatic osteotomy, so that the pressure on your temporal lobe will be, your traction temporal lobe less, drilling with the temporal base, expose the middle meningeal artery, coagulation and cutting, expose the V3 division, separation of temporal dura along the endosteal dura. The two layers of dura are present in that. Second, next is the exposure GSPN and the sharp dissection, so that to prevent any injury to it, and the facial nerve, and the exposure covers rhomboid and drilling. Complications, brain contusions, venous injuries, seizures, in the 5th, 7th and 8th nerve while drilling, cochlea can be opened and damaged. This is one case, one is a large petroculum meningioma. I'm giving a small video. This is the coagulation of the middle meningeal artery. Forward. Now the exposure of the V3. So these are the landmarks, middle meningeal artery. Then the exposure once going behind the temporal dura, or separate temporal dura from the endosteum, you expose the Kawase rhomboid. Then gradually you remove the periosteum to expose the petrous series. This is the petrous series where the behind. This is the petrous series. Now this is where the medial mobilization of the gastric ganglion, so as to have better drilling and exposure. This is the drilling being done. Kawase quadrangle has been drilled, premeatal part. Now, once the bone is thin, you can use a kerrison. So you can do the bleeding from the meningioma, the dural meningioma, from the dura overlying the meningioma. Now, this part of the bone has to be. Now, this is the opening of the temporal dura in a T-shaped manner. The CSF is egressed. Now we are cutting the superior petrosal sinus, coagulating and cutting it, and making the two compartments in one compartment. This is we are doing the cutting of the tentorium. so as to a better exposed tumor. The tumor is exposed and it is decompression and been separated from the brainstem with exposure of the vessels. So another case was presented in January 2019. It's basically a fifth nerve schwannoma, Jefferson grade type 1 tumor, which confined only to the middle fossa. We operated in subtemporal external approach, neutral excision was done, where a small part was cavernous sinus, the histopath came out to schwannoma. The tumor remained same for next 3 years, a small part in cavernous sinus, then it regrew into a large Jefferson type 3, a very large tumor, extended into both posterior and middle fossa, and we decided to operate through the approach, middle fossa approach. Now this is the thing, because the tumor was extending the cavernous sinus due to the orbitomeningeal band coagulation. To remove the temporal dura, separate temporal dura, temporal dissection was done from the endosteal dura. Then we did the removal of the middle fossa extradural tumor with the help of CUSA. Then it was separated from the cavernous sinus. Sorry. So this is the now after that you can see here the GSPN is there. The GSPN is the exposed carotid because already the tumor had eroded into that, and this Kawasaki quadrangle has been very much thinned out by the tumor, and we have to can remove it by just Carison. We don't have to drill it. In trigeminal schwannomas, the bone is already thinned out. Usually the natural corridor is made of the tumor. And this is where we open the temporal dura, excise the temporal dura. Then again same thing, coagulating and cutting the superior petrosal sinus. Now you can see the fourth nerve stretched over the tumor. This is the internal decompression of the interdural part. This is the tumor interdural part. Decompression is being done. Now it is gradually and very carefully separated from the brainstem, modulation tumor from anterior side. Sometimes the corridor is not enough to remove the tumor completely. So we have to extend our bony exposure. This is being done separately. Tumor is being separated from brainstem vessels. This is done very carefully. Our corridor is small. Now we have to improve our corridor, so increasing Kawasaki corridor. But drilling has to be very careful so not to enter into the cochlea. There's cochlea at that point. And sequential dissection of tumor all around the tumor has to be done. And finally tumor is removed. Almost gross total neutral removal done. So this is the tumor bed. So this was the post-operative imaging, remove the complete removal of the tumor. So this is till the extradural anterior petrostomy. What I am now discussing is the intradural anterior petrostomy. This was one extra part given to me because S.K. Gupta sir was not present and he has to present this topic, intradural anterior petrostomy. And disclaimer is that I don't have any personal experience in intradural anterior petrostomy, but I am just presenting as a theoretical part. What are the differences or what are the advantages of intradural anterior petrostomy over external anterior petrostomy? In that case, our anterior petrostomy can be tailored to the individual needs. If the tumor is small, the anterior petrostomy can be made small. In this case, the first dura is opened. You can see the picture. Here, the dura is opened first, temporal dura. The cistern is, the ambient cistern is opened. Then the superior petrosal sinus is coagulated, and then here the petrostomy is done under neuronavigation or by palpating the petrostomy with some kind of instruments where palpate it and then drill petrostomy in a blind manner. So the disadvantage is a lot of chances of venous injury is more because we are doing intradurally. Localization of petrous drill is difficult and SPO coagulation is difficult. So to summarize, the middle fossa approach for posterior fossa lesions is a very beautiful surgery using the corridor created by removing a bridge of bone while avoiding the critical nervous structures. It is the shortest transcranial trajectory for petrocular region and pons. It's the least manipulation of posterior structures, and it's a step-down surgery coming from supratemporal to gaining access to infratemporal compartment using fusion of compartment technique to increase the angle of attack and exposure. Okay, thank you. Here you
Thanks,
work,
Ashish.
the same finisher.
Thanks, Ashish. As all the lectures are done in this session, any questions? If no questions are there, then this session is.
Excuse me, sir. For reaching the petrous apex, did you also drill the foramen ovale and the mobilization of the V3 segment?
No,
Or
no,
with this
you have to drill the foramen spinosum sometimes. Because you have to sometimes, the middle meninge is small, you have to coagulate, sometimes drill this foramen spinosum.
That is the first step. For mobilization of V3, did you ever...
No, you don't have to V3 mobilization, you have to mobilize your gastronic ganglion there.
Okay, with the Kawasai's quadrangle only.
Yeah, this is extended Kawase drilling. Okay.
You could reach the apex of the petrous also.
Yeah, once you reach the apex, you can just mobilize the gastronic ganglion, who is sitting over that cave. You have to just mobilize anteriorly. So you will get a more extra space to drill.
Mobilization of V3 was not
No, it's not required. V3 is almost continuation of that Michel's cave anteriorly.
Now this session is over.
Starting with the next session, session 7, that is middle cranial fossa part 2. The moderator for this session is Dr. Subhash Konar. May I call upon the stage the honorary chairpersons for the session, Dr. Sunil Pandit, Dr. Sudhir Pal, and Dr. Raghav Iyengar. May I call upon the stage the honorary chairpersons for the session, Dr. Sunil Pandit, Dr. Sudhir Pal, and Dr. Raghavendra Iyengar.
Hello. Shall we start? So, not taking much time, we'll call the first speaker for this session for the middle cranial fossa part 2, Ramakrishna Ishwaram from Trichurapalli. He is going to speak on the trans-pterygoid approach to skull-based pathologies. Over to you, sir.
Thank you, Dr. Adesh. It's been a very nice meeting, a lot of learning from morning. And I'm sure you had a very good workshop yesterday in which many of you have seen and possibly done also the endoscopic trans-pterygoid approach. So this is going to be just a revision. And it's going to be a personal perspective of the endoscopic trans-pterygoid approach. Now, I work closely with two of my ENT colleagues, Dr. T.N. Janakiram and Dr. Shilpi Bhatia. And these are the people from whom I've learned a lot about skull base. And they have been helped a lot by the presence of a neurosurgeon in their team for dealing with these cases. So I think all young people who are starting to do skull-based surgery should start developing teams like this, where each person's role is well defined and who's going to do what. So, because it's an instructional course, I thought I'll start with the basic anatomy. Everything revolves around this particular area of the sphenoid bone, which is hanging down from the body of the sphenoid. The two pterygoid processes, the medial and lateral pterygoid process, which are connected by the pterygoid wedge, and that is attached to the sphenoid bone. This is, if you look at it from the inside of the nose, on the lateral wall of the nose, you will find that the medial pterygoid plate forms the most posterior part of the lateral part of the nose, lateral wall of the nose. So just removing this gives access to many of the lesions. Some of the lesions look will look very similar to what Dr. Ashish showed you in the previous talk. It will give you access to the lateral part of the lesions that are going into the cavernous sinus, lateral recess of the sphenoid. It's extending very far laterally sometimes. And, sorry, it's running. I don't know why. It's not going to the next slide. Okay. It also helps you to approach the Meckel's cave, Petrus apex, lateral clivus, and the jugular foramen all the way up to the jugular foramen. Oh, this is going fast. I don't know what's happening. Can you help me here? It's not going to the next slide. It's going to 10 slides beyond. This one, no? This one. Okay. I have one more thing here which comes up. Okay. And far laterally, it can also take you to the infratemporal fossa. Now, the important thing is to understand what are the vessels and nerves that you're going to encounter over here. You've already seen this Vedian canal right from the morning and also in the anatomical talk by Dr. Sukhdeep. And this is the nerve of the pterygoid canal, comes through this pterygoid canal. And it is an important landmark because it is the one that will lead you to the carotid artery. And that's why it's so important to identify the Vedian nerve and not get confused with anything else in this location. And there you can see the sulcus tubae, the relation of the Vedian nerve to the internal carotid artery. And it's very important to realize that the amount of bone over it may be variable. It may not be always covered by an entire bone. We should also not get confused with the other two false foramen or false fissures that are there, which can sometimes mimic the Vedian nerve, which are more anterior and more medially located. Very important thing is to study the CT of the patient before you go into surgery, and that is vital. The coronal sections, these are the various landmarks that are marked out for you. I'll tell you why this is important, because this forms a kind of a pentagon, you know, like pentagon in the US. This is a very important pentagon for you to realize. Right from the rostrum of the sphenoid, if you keep going laterally, you'll reach the median and then you'll reach the rotundum. Right. Now that is a very important slide to focus on, because you can see that the entire pterygoid apparatus is behind the maxillary sinus. So if you want to remove all of the pterygoids, you have to go to the maxillary sinus. But if you want to remove only the medial part of the pterygoid, you don't have to go to the maxillary sinus. Most of the textbook descriptions of transpterygoid approaches will tell you that it is a transmaxillary approach. Whereas here I'm going to show you a case, many cases in which we have done just the medial pterygoid plate removal, which has given sufficient lateral access for us to deal with some of the pathologies, not all of the pathologies. So you can restrict and you can limit the amount of bone removal depending on the pathology that you're going to deal with. It also depends on the pneumatization of the sinus. It's very variable. Sometimes it goes very far laterally. In this case, you cannot go to the lateralmost part of the sphenoid sinus or the Sternberg's canal without going through the pterygoid in this patient. Right? But whether this is really a lateral craniopharyngeal canal that is causing the CSF leak or not is a matter of doubt in the literature. So the initial steps are all very familiar to all of us. It's a binocular forehand approach. Inferior and middle turbinectomy on the ipsilateral side, the side of the lesion. We have to plan for the reconstruction, because we will be going through the sphenopalatine artery, which is the main supply to the Hadad flap. And therefore, we have to plan for the opposite side Hadad flap. And if the opposite side Hadad flap has to come through, there has to be a septectomy, there has to be a flattening of the whole of the rostrum of the sphenoid. All these are taken for granted in this kind of procedure. So posterior septectomy, removal of rostrum, wide sphenoidotomy, removal of any sphenoid septa, all these are normal steps that you do even for a pituitary. Then there are two variations in this approach. One is without maxillary sinus entry and one is with maxillary sinus entry. The common textbook description is of that with the maxillary sinus entry. So I'll show you the other cases where we can do this and how I plan this approach. So this is the same coronal picture that I showed you. If you can draw a vertical line like this between the two pterygoid plates, and if your pathology lies medial to this line, then it's possible to approach this without any opening of the maxillary sinus. If it lies lateral to this line, then you have to open the maxillary sinus, you have to remove the pterygoid plates, you have to either lateralize or medialize the contents of the pterygoid fossa, depending upon where your pathology is situated. So this gives you access to paramedian lesions, the sphenoid, cavernous sinus, paramedian clivus. Like for example, this pituitary adenoma, NOS 3B, was removed by just removing the medial pterygoid plate through the nose itself. So this is not a very difficult procedure to do. And also this patient who has chondrosarcoma, again the same thing has been done. You can see how far laterally we have been able to reach without actually doing a maxillary sinus entry. You can see it in the post-operative pictures below. Now, transmaxillary will be required whenever the pathology is lateral to that line. So here we have had to remove, this was a fungal granuloma, the entire sphenoid, the maxillary sinus has been entered, the posterior wall has been taken off, the contents of the pterygoid fossa have been lateralized, and then we have entered into the lesion that is there, lateral to this line that I spoke about. Look at this patient, we thought this was a meningioma that is extending from the middle fossa through to the infratemporal fossa with relation to the carotid arteries. The first procedure was done as a transmaxillary procedure, and in order to reach so far laterally, you also need to remove the anterior wall of the maxillary sinus. You can see that in the postoperative CT. So this is a modified Denker that has been done, and all the anterior wall has been removed, so you get a lot of room to maneuver your instruments. And then, because we could not remove the entire mass, I then had to do a subtemporal approach and remove the rest of the mass. And unfortunately, this turned out to be a plasmacytoma. We had to irradiate the patient. Now, this is another lesion, small, not very large, but still it is lateral to that line, and therefore we have had to do a proper full transpterygoid approach. So I'm showing you all this only to tell you which are the kind of lesions which you can manage with limited opening and those in which you need to be maxillary invasive in the nose. So this is a patient who has a trigeminal schwannoma, very similar to the patient which Dr. Ashish showed just now. But then it is a little smaller in size, that's all. And this we have been able to do entirely through the, how do I run that video? So this is after we are decapping the cavernous sinus bone over the cavernous sinus, mobilizing the carotid. This is a trigeminal schwannoma. Soon you will see that we'll be entering into the main lesion. It's important to make sure that the carotids are well mapped with Doppler during this procedure. And the navigation is very useful in this kind of a procedure. So there are more videos which show that we go into the Meckel's cave from below and remove the tumor without having to do all that temporal lobe retraction that we would have had to do if we had to do through the middle fossa. I don't have time to show these videos, so I just skip and go to the next ones. All of them are playing simultaneously. This is the first stage, second stage, third stage. That's the final after removal of the tumor in the Meckel's cave. We also use this for lateral sphenoid recess leaks. And here again we have to do this is showing you the medial maxillectomy, the first video there. And this is drilling of the posterior wall of the maxilla. Here we'll encounter the sphenopalatine artery which will coagulate. Sometimes it needs a clip and coagulate and cutting. So that's how we approach the lesion. The important thing is to be end-on, and that's why we need to go so far laterally. Unless you are end-on, you will not be able to repair. With angled telescopes, you will not be able to do it. With straight telescope, if you are able to get an end-on view, your closure will be perfect, and you'll always use a Haddad flap coming from the opposite side. There are complications because you lose the median nerve most of these cases. And this is a summary of our 17 cases. What we have learned is that the extent of pterygoid resection can actually be modified, and it can be minimized depending on the need of the patient. And we should study the coronal CT and MR images, and that gives us the ability to decide what is going to be done before operation. And we should plan for reconstruction before starting the procedure. Thank you so much.
Thank you very much, sir. I'll invite the next speaker now. We'll take the question in the discussion session. The next speaker, he doesn't need any introduction. Professor Goel, legend by himself. He'll be speaking on his philosophy, as I know, on surgery for confined cavernous sinus lesions. And I am like proud to be associated with him. He's an adjunct professor to our institute now. Thank you, sir.
Thank you, Raghav. There was a movie Around the World in $10. I'm not sure if you have heard it. So I will talk on around the cavernous sinus, my life story in few minutes. And do you have a pointer? Where? Okay. So this is my story, and I want to, the young neurosurgeons, which one? To, if at all, to encourage you and to stimulate you and maybe to, mold you a little bit. I give you this challenge. This is my publication number in PubMed journals. Try to beat me if you can. I know it is difficult, I know, but there are some people I know who are in line and they might probably do this. And I'm a little worried all the time. So out of this 805 number that you see, there are more than 350 articles of mine that have a new technique, which you should see. The negative part of the story is, out of the 805 that you see here, there are more than 80 to 90 papers which are letter to editor because somebody has not referred to my work. And somebody, when you say these are my papers, they are your children. And if somebody does not acknowledge your child, it is a little bit irritating, to tell the least. And this message I want to give to neurosurgeons, skull-based neurosurgeons in India, that they so proudly take some names, but they little bit hesitate to take some beautiful name that you will like to take, and I wish that you take, and I want to show you that work. So my journey is more than 40 years. In cavernous sinus, I gave one lecture in my department when I was about to complete my residency in 1986, and since then, this has been a beautiful journey of mine on cavernous sinus, and many of you have heard me several times. Even if you have heard me, the reference does not come, so that is a little bit bothering. So this book of mine in 1996, you see 1996, can you believe, about 30 years ago, this was the entire story of cavernous sinus. And this book of mine is a monogram. The whole book has my own personal techniques. There are more than 150 techniques of mine which were mine. When I say mine, they are published. So in 1996, there were so many techniques, and I wish this book has been reprinted thrice, and I wish you read it. And these are my children, and I wish that, you please try to acknowledge my children. So as far as cavernous sinus is concerned, I have actually spent my beautiful time on cavernous sinus, on thinking about cavernous sinus, on speculation about the function of cavernous sinus. And there are many beautiful articles of mine. These articles, in my view, are complete fantastic. Speculations about the function of cavernous sinus, speculation about the role of cavernous sinus in vision, speculation about similarity of cavernous sinus with, the cavernous sinus of the testes. So many. Means there are some, about at least 30 or 40 beautiful speculations. When you push the eyeball, what happens? How the cavernous sinus protects your retina. When you lift weight, why your eyes do not pop up. These are speculations of mine, which were beautiful, but I don't see too many people even thinking about it, even talking about it, forget about referring about it. This slide, many of you have seen several times. I have given this lecture more than 200 times. Why the eyeballs of the lion are in front, why the eyeball of a deer is in this position. This has beautiful relevance to cavernous sinus, beautiful relevance to the functioning of cavernous sinus. Its role in eye movements. You see, when we talk of eye movements, we only talk of sixth nerve, third nerve, this nerve. We never talk of cavernous sinus. My article on how cavernous sinus venous circulation takes the control of eye movements, not only eye movements, how it regulates vision. So these are off-center articles, these are lateral articles, but these are interesting and possibly and probably very contributory to the subject. And also original. Nobody has talked about it. Why the pituitary gland is located outside the skull or inside the skull, whether it is intracranial or extracranial, why it is located by the side of cavernous sinus, why it is located by the side of carotid artery, why it is located by the side of paranasal sinuses, some beautiful speculation. And I wish at least these young people who want to, little bit go off center can read these kind of philosophies. The other beautiful thing that you have heard me talking about several times about the dura mother. Mother dura, and you will not believe that there are at least 60 articles of mine on mother dura and its relationship to the skull-based tumors. So this dura is the most fascinating structure. It separates the spiritual environment of the brain from a zoo of animals in the paranasal sinuses. There is no terror of error in dura. When the dura goes, when the artery goes out or whether the nerve goes out, the dura takes care as long as it goes and wherever it goes. So dura covers the structure when they go in and when they go out. There is no hole in the dura. And this is a very important thing which I am saying. There is no hole in the dura. When the artery goes out, it does not go make a hole in the dura. Believe me or not, great surgical relevance, clinical relevance, surgical relevance. And since 35 years, if you go through the history of my own papers, you will see several beautiful articles on cavernous sinus. During 30 years ago, not many people talked about cavernous sinus. 30 years ago, not many people understood cavernous sinus. Even today, not many, I'm sure not many understand. Many talk, but understanding about the subject, understanding the intricacies, understanding the possible problems, the delicacies and the beauties of cavernous sinus is for us to understand. And you see, when the cavernous sinus surgery was born, MRI was born. Carotid artery relationship could be seen on MRI. This information was not there on CT scan. So this, many of these cases, these are like my trophies. I like to showcase my trophies all the time. 1993, I operated 33 years ago. Imagine this tumor, extensive bone work, and many. See, I have worked in cavernous sinus day, night, and all the time. And I have enjoyed it. I have probably learned it. Whether I have completely learned it and I have won it, I cannot be sure. Nobody can win cavernous sinus. Difficult, dangerous, and probably the most beautiful structure of the human body. Not just by anatomy, but by function. The whole body is beautiful, but cavernous sinus is indeed fantastic. So these kind of cases which we did in 1997, I am showing this case in 1997 because I remember this case. And there are some things which have to be remembered in this case, and those things we will discuss some other time. We always talk of Dolenz talking about intradural aneurysms. How many times you have heard somebody saying Dr. Goel described tumors involving cavernous sinus in extradural approach? Have you heard from any Indian neurosurgeon? You have probably not heard, because when the name comes Indian, you try to either hide it or ignore it or abandon it. Extradural approach to, even Vinko Dolenz referred to this article, that this paper was the first one in the literature describing extradural approach to tumors involving cavernous sinus. Cavernous hemangioma of cavernous sinus, one of the most dangerous, difficult, vascular, and confined tumors it is primary intracavernous sinus tumor. If you do not understand this tumor and come from the nose, you probably will have a disaster at hand. These tumors are primary intracavernous. This case in 1991 was the first case in the literature where total resection was shown by pictures, pre-op and post-op images. And these tumors, whether they grow big or whether they are small, they respect the dura. And my dear young skull-based surgeons, you must know that extradural approach to these tumors was first described in this article in the year 2000 on the basis of 13 cases. So I was doing this approach for at least 5-6 years ago before I described this approach. So you remember, you just cannot put under the carpet, and trying to ignore Indian work under the carpet may not just be a crime, it is not good. It is not good, and I don't like it. Whether I like it or not, it is not your business, but it is my heart painful business. And cavernous hemangioma, we have got the largest series in the world. Giant pituitary tumors. I have to say clearly that I revolutionized pituitary tumor surgery. You will say how you revolutionize. One is by several articles on the subject. Large tumors, when they grow in size, they grow huge in size, but they have a pattern in this madness. This concept, Jules Hardy said that this tumor opens the diaphragm celli and this part of the tumor is subarachnoid in location. This is Jules Hardy's written article. For the first time we said the diaphragm dura goes up and this entire tumor is within the confines of mother dura. Believe me or not, this concept has completely changed. Before, in 1995, 90s, all these tumors were done transcranial. You see this dura elevation. There is no question, this concept has changed, but how many of you, when you talk of pituitary tumor, refer to this work, particularly from India? I see references when I go abroad, people talk about it. But how many have you seen when they talk about from India? This is dura, this is not this is intracranial, but this is intradural. This is intracranial, but under the dura. If you do not have this concept, you cannot do this tumor. If you think this is subarachnoid in location, then the arterial relationship will be absolutely intimate, that you cannot do it. If you know that there will be a dura here, you can remove this tumor beautifully and quickly. And believe me, some of these tumors I remove in 30 minutes or 25 minutes. I'm putting a little bit more time because you should not get a little bit jittery about it. But these tumors can be removed in quick time, and this dissection from the brainstem can be done remarkably easily if you have this concept. How the tumor goes in the cavernous sinus, we describe for the first time in the literature. What is the medial wall of the cavernous sinus? Why these tumors go along the medial wall? This was my description. Elevation of the dural roof of the cavernous sinus, we describe for the first time. How many of you have heard from Indian presentation that this dural elevation was first described? Have you ever heard? This technique, that technique, we very proudly take names, but have you seen people talking that this dural elevation was first described by us in the year 1994? This is elevation of dural roof of cavernous sinus. This is elevation of dural roof of cavernous sinus. Nobody knew. And believe me, I have written at least 4 letters to editor in Journal of Neurosurgery. You must read. That person did not refer to my concept in his article. So this is dural roof, this is diaphragm, so the entire tumor is under the confines of mother dura. Believe me or not, this concept has changed pituitary tumor surgery. Very rarely it encases the arteries of in the subarachnoid location, arteries of circle of Willis, those tumors are different. So this is my classification, and I believe this classification has great merit if you understand the anatomy of large tumors. But you see the hesitancy you will see when you see the rest of the presentation. Grade 1 is when the diaphragm goes up. Grade 2 when cavernous sinus is involved. Grade 3 when roof of cavernous sinus is elevated. And when the arteries are encased, that is grade 4. So this was my classification. There is no question this changed the destiny of pituitary tumor surgery. It is not endoscope that has changed. It is not microscope that has changed. It is this concept that has changed. And I do just this operation, just this removal, and break into the tumor, and many of these tumors can be removed in exactly 15 minutes. And you give a new beautiful life. And these tumors, subfrontal extension, there is no need for transcranial. You can come here and remove this tumor. This kind of extension, probably the whole world would have done transcranial 30 years ago, and now these tumors, and this was done 25 years ago. Can you believe with my concept that just this extension is under the dura? If I do not have this concept, no, I cannot do this. In 1999, I did this tumor just by anterior wall resection. So you can imagine this concept, how to remove cavernous sinus portion, how to remove the part going inside the roof of the cavernous sinus are different stories. How to remove the tumor when it encases the arteries, that is a different story. Trigeminal neuronoma, you have heard so many presentations. Even today I was hearing, how many of you have said that this interdural approach was described in this article for the first time in the literature, that this part of the tumor is within the confines of mother dura. You work within the dura, you don't have to expose the carotid, you can save the trigeminal and you can save the various structures. This article is highest cited article in trigeminal neuronoma surgery. You can see the literature. Various things were mentioned in this, that trigeminal neuronoma arises in the Meckel scale. It remains within the dura. In this article, we had said this part is subarachnoid, but later we changed even this concept. So this paper in 1995 or 1993, you can imagine we did cavernous sinus tumor without opening the skull by this interdural strategy. So this tumor in 1995 without opening the skull, this tumor going in the posterior cranial fossa, this kind of dumbbell tumor without craniotomy in 1994, 31 years ago, by this concept that dura, it is interdural in location, the clinical features are characteristic, you can diagnose. You know, at that time, whether it is meningioma, whether it is this, that, okay, but clinical features are characteristic. So this was also in that paper in 1995. I did without craniotomy. Of course, I don't do it now, but understanding the concept that this part is interdural, you better recognize this, who has described this. Just don't be fascinated and very proudly say some names and try to ignore the Indian contributions. I think this may be a derogatory thing for the Indian contributions in neurosurgery in general and skull-based surgery in particular. So trigeminal neuronoma, my personal series is by far the largest in the world. And for larger tumors, we have described various kinds of approaches, skull-based approaches. Now, of course, my technique is I do a very smallish kind of exposure. With more and more experience, I can work within the dura with much more ease, and how to go in the posterior fossa, how to remove the, how to take the tentorial incision, how to protect the superior petrosal sinus, how to protect the cranial nerves. My article was the first one that in the literature where we said you can improve the sensations of the trigeminal nerve. This, as a series, this was the first article. So these kind of tumors we have got, you know, when I see these kind of patients, you know, there is some kind of beauty in my, you know, I just get excited and happy because I know that I can give a beautiful new life to these kind of patients. And I have got several. Trigeminal neuronoma with extracranial, this is the largest series published. Even extracranial is within the dura, whether it is V1, whether it is V2. And this, whether, you know, it is not the dura. It has got great clinical relevance, surgical relevance, how to approach the carotid arteries displaced medially. You should not come from the nose for these tumors. These are carotid is displaced medially. You work within the dura and you can have a beautiful resection. You know, the issue is, and whenever the tumor recurs in an apoplectic fashion, even the recurrence is within the dura. This is one beautiful article that you will like to read. Third nerve neuronoma. You see, how many of you skull-based neurosurgeons will first thing is find whether it is diagnosed as a third nerve. So this neuronoma is also within the dura. Unfortunately, you see this. This is interdural in location. This is within the dura. You have to work within the dura. You have to protect the dura. This is 7 nerve tumor, arises from the geniculate ganglion within the dura. These tumors can remove in good time. You know, you don't have to have a massive exposure if you understand the dural integrity. Interdural, this was one beautiful article of mine. So when you talk of lower cranial schwannoma, have little bit, you know, go and read this article. You will get some information. This article was the first one in the literature which said that as a, you know, all patients improved in lower cranial. There is not a single series in the literature which mentions about improvement in function. Work within the dura, avoid going outside the dura, and you can not only save, but you can improve the function. So unfortunately, you see, the story of mine is rather too big to be covered in little bit lesser time, but as far as I am concerned, cavernous sinus is an anatomical issue. Chordoma, this is chordoma, just my dear chairman, give me a few minutes more. Chordoma is an absolute skull-based beauty, absolute. These are extradural tumors. They displace the carotid artery anteriorly. I described it in 1993 or 94. How many of you know it? You talk about, I know somebody of you may be knowing also, but they don't want to refer to this. Trigeminal nerve is displaced superiorly. Sixth nerve, which should go along the carotid artery, is divorced from carotid and goes along with its brothers in this part. And this part is completely bare of all nerves and arteries, and you can have a lateral, beautiful exposure. And this was the article in 1995, carotid is displaced anteriorly. Many of you have seen it 100 times, this art presentation. You have seen, you have heard, but you have finally ignored it. So middle fossa subglycerine ganglion approach, one of the most fascinating approaches to clival chordomas. Of course, many of these chordomas can be removed from the nose. And my last thing, which I have several more things to show, but I will show you supracerebellar approach to clival chordoma. This is clival chordoma. You can come from the nose. You can come from lateral. But sixth nerve is displaced posteriorly. If you come from the nose, you will reach the sixth nerve last. So to save the sixth nerve, you can, this supracerebellar approach is the most beautiful approach. And you can try this approach. This is the tumor. This kind of tumor can be. I'm sure the nasal approach is also good. Middle fossa group is also good, but supracerebellar is also fantastic. And there are other issues of cavernous sinus, meningiomas, and things like that. So my life goes on in cavernous sinus. I have enjoyed cavernous sinus like probably nobody has. I have got an opportunity to operate that my hospital gave me. I became a neurosurgeon when I was 26 years old. I became head of department of KEM when I was 36 years old. And that journey of mine has been divine. And I challenge you, follow me. If you win, I will be happy. Thank you very much.
I would like to invite next speaker, Dr. Kamlesh. He will be talking about Dolenk approach to cavernous sinus lesion.
Thank you, Chairperson. It's a very difficult job to talk about cavernous sinus after Professor Atul Goyal. I will try to do some justice. So my topic is Dolenk's approach to cavernous sinus. And my initial experience, I would like to share with you. The cavernous sinus used to be a no man's land in the last 30 years back. Now various approaches in the literature have defined with the work of Professor Dolenk and Hakuba, and various surgeons have given approaches to how to safely approach these lesions. So what are challenges? Challenges in these lesions are due to complex anatomy of cavernous sinus, neurovascular structure involved, bleeding, one of the major factors to approach the lesion, and sometimes exposure may be not be adequate. So all these factors increase challenges during these surgery during these lesions. So first of anatomy, we should be well versed of anatomy. This various triangle and CF areas has been defined in literature. We should understand where we are going to approach these lesion, intracavernous lesion and paracavernous lesion, or transcavernous pathologies if we are dealing. So this is a beautiful cadaveric study which define the Dolenk approach is beautiful 12 steps, 6 extradural, 6 antedural. Everybody should read it to start practice this Dolenk approach in cadaver also. And these steps which helps in disengaging releasing various neurovascular structure before approaching for tumor or any pathology. And for bleeding purpose, the fibrin glue gives very good result whenever we approach bleeding in this patient, which can inject glue tissue sealant in the cavernous sinus to control the bleeding. And how, when and where it should be done, I will discuss in later. So as Professor Goel already gave insightful lecture in cavernous sinus, and how we are going to deal with this lesion depends on pathology. So preoperatively we should know which pathology we are dealing and how to go about it and what is my goal of this surgery. Accordingly, we can tailor our approach to these lesions. The first case I am sharing is a case of recurrent pituitary adenoma. We can see it is patient already operated twice outside, and third MRI we can see that the gross cavernous involvement in this lesion. The standard frontal terminal craniotomy was done. We plan to do this transcavernous, and we can see we are delineating meningo-orbital band and releasing the cavernous sinus. You can see fullness of cavernous sinus due to tumor below. Meningo-orbital band being cut here sharply on the surface of ventricular process. And we are opening the interdural duplication to cavernous sinus. Then we are adding the anterior-clinodectomy. It is must, I think so, all these procedures to decompress neurovascular structure, expose a Dowling triangle. Sometimes tumor can be spreading to this triangle, and we can have better control on ICA and early decompression of optic nerve. Now we can see there is a Dowling triangle, ICA, third nerve, and clinodal triangle. And clinodal ICA we can take control here if needed. We are opening a dural duplication up to V3. You can see V3 at, yeah. Dura is opening beautifully. We can see all cranial approach, we can identify as much as we can. And this is the after opening of whole dual duplication. We can have full, this is a region of third nerve. We are releasing some bands here. And after that, intra-monitoring may help in these, identifying these nerves, especially in large tumor, which can be difficult to identify these nerves, maybe displaced and maybe thinned out. And we are making the entry into cavernous sinus, the various corridors, and decompressing the intra-cavernous part of pituitary adenoma. And as we go on, the cavernous sinus bleeds because it decompresses, because due to tumor, it has some compression effect, and as we remove the tumor, the bleeding comes back, and this photo, the hemostatic material can help them. Then we open dura to remove the intradural part of this tumor. The patient did well in the post-op period. Now, another case, this case is a 26-year-old female patient. We can see large cavernous sized lesion with bony involvement here, which is rising of petrous going inside the cavernous sinus. The tumor is T1 hypo, T2 hyper, contrast enhancing. Our pre-op diagnosis was of it can be bony tumor involving cavernous sinus, maybe chondroma, chondrosarcoma. A similar approach here after extradural craniotomy and opening a dural duplication. We can see the same approach, opening a dural. We are using intra-monitoring to identify our nerves, making corridors between these nerves and remove. Tumor is very soft, suckable, ideal, chordoma and chondrosarcoma type of patient. There is no difference, no difficulty remove tumor, but as we go on remove the tumor, the cavernous sinus starts bleeding. Then we need to have patience. We can see we open all corridors. We can see intracavernous carotid artery. We have identified here. Dowling triangle, third nerve. We are all decompressing. We can see there is no retraction on the brain. All work is extradural. We can see petrous apex where the tumor is arising, petrous bone. And we have identified petrous ICA, all this region, because the bone was eroded due to tumor. But a complete excision of tumor, some flow seal or T-seal may help in the controlling of bleeding post-operatively. So there was no retraction of brain, all done while tumor was done extradurally. And post of MRI, we see small residual lesion and petrous part of bone for which that patient was advocated adjuvant radiotherapy at our center. Next case, when you see 20-year-old female patient, the giant, large cavernous hemangioma. Our approach, similar approach for opening of supraorbital fissure. Another thing, there is a cutting of middle meningeal artery and foramen spinosum. Sometimes it may help to devascularize tumor before reaching the tumor. We can identify V3, cutting of meningoorbital band, opening of dural duplication. Similar approach, colonectomy, decompression of Dowling's triangle, colonal triangle. And we can see the tumor bulge on cavernous sinus. Trying to identify various nerves on the surface of cavernous sinus. Then we are making plane all around the cavernous hemangioma. By coagulating it, we are not going inside it. It may cause bleeding. So dissecting it all around. Now you can see cavernous ICA. There's a beautiful cavernous ICA. Tumor is we are lifting tumor from cavernous ICA. It is straightened up. And this is a region of meningohypophyseal artery. We have coagulated and cut it. Completely devascularized tumor, removed it in 2 pieces. And we can see complete cavernous ICA inside, complete in control, and hemostasis post-operatively. This is a post-op CT of the patient, which shows gross total oxygen of the patient did well. And another issue is from meningioma of cavernous sinus or meningia involving cavernous sinus. It's a 48-year-old female, we can see a large meningioma arising from the medial sphenoid wing and going inside the cavernous sinus. We can see how much differential intensity of tumor which are outside the cavernous sinus, which is inside the cavernous sinus. So, this beautiful paper which beautifully describes the total indication of surgery for meningioma involving cavernous sinus. It is only due reduction of tumor volume by preserving the cranial nerve function, decompression of optic nerve, and direct decompression of cavernous sinus, and opening a lateral superior sinus. These are the indication for meningioma, cavernous sinus meningioma. But tumor which are involving cavernous sinus, we have to remove the extra cavernous sinus tumor and leave behind region. We can see this is we have removed, amputated tumor from the cavernous sinus region. We have left the tumor at cavernous sinus. How this cavernous sinus is bleeding? Because we have decompressed the sinus. Simple surgicel packing may control this bleeding. And we going along, devascularized tumor, lifting from it's all around. It has beautiful plane from ICA and optic nerve and third nerve. We have lifted it by soft dissection. This is tumor excision. You can see the part of tumor attached to cavernous sinus, which leave behind to preserve neurovascular dysfunction. We can see this, showing. We can see the neurovascular bundle behind this tumor. This was left behind, and this is a complete after the tumor extra cavernous removal of extra cavernous part of tumor. This is the post-op CT. We see the small residual lesion in cavernous sinus. This would be the approach for this meningioma involving cavernous sinus. To conclude, my learning till now are
for safe cavernous sinus surgery is the full exposure of cavernous sinus, early identification of cranial nerves, excellent control of intracavernous carotid artery, maybe in Glackox triangle or inside the cavernous sinus, extradural retraction of brain, preserving Sylvan vein, bridging vein, and spiloplatus sinus, which will talk my senior Professor Arun later this talk, and good control in bleeding. These are my learning how to do safe cavernous sinus surgery. Thank you.
I would like to invite Dr. Arun Srivastava sir. He will be talking about mobilization of the sphenoparietal sinus in middle cranial fossa approaches.
So, my journey towards a pretemporal transcavernous approach started almost 2 decades back with initial hesitations, wavering confidence, translating from cadaver to a clinical scenario, successfully traversing through level 1 of a pretemporal transcavernous approach to the level 4 of the pretemporal transcavernous approach. And most of you must have witnessed my passion toward this elegant approach. And during my expedition, I had my own experience and learning regarding the nuances which are not mentioned in the literature. And one of the very important nuances being the mysterious story of this drainage pattern of dominant sphenoparietal sinus in and around cavernous sinus, and I used to call it as a 5th level of pretemporal transcavernous approach. So ladies and gentlemen, I'm going to unravel this mysterious story in front of you. So this is the axial view of cavernous sinus showing the normal drainage pattern, but actually when you are doing pretemporal transcavernous approach, in 50% cases you will find a dominant vein running over the temporal dura propria and draining towards the anterolateral part of the cavernous sinus. This dominant vein could be a dominant sphenoparietal sinus when the superficial middle cerebral vein is draining through the sphenoparietal sinus, or this is only a dominant superficial middle cerebral vein which is draining to the cavernous sinus by making Cree pattern. The first and very important and commonest is the cavernous variant, where this vein must be draining between the V1 and V2 division of the 5th nerve. Then the second variant is the lateral variant, where this vein, dominant vein, first entering between the 2 layers of the cavernous sinus, that is the true cavernous membrane and the outer cavernous membrane, then it will be traveling posteriorly. Then it will be draining either to the posterior part of the cavernous sinus, or it will be draining to the pterygoid venous plexus, passing through the foramen of ovale, most commonly, or foramina rotundum. So what happens in 50% of cases when you don't find a dominant vein over the dura? Actually, in those cases, the superficial middle cerebral vein drains through the deep middle cerebral vein. So this is a operative photograph of right-sided approach. See the beautiful Dolling's triangle, optic nerve, 3rd nerve, clinoidal ICA, 4th nerve, and you see this dominant vein. It's going and draining between the V1 and V2 distribution of the 5th nerve. Again, a right-sided approach. You see a vein, dominant vein, entering in between the 2 layers of the cavernous sinus, the true cavernous membrane and outer cavernous membrane, and it's also draining between the beyond the V2 and V3, but it is traveling here and then finally it's draining to the pterygoid venous plexus while passing through the foramen of ovale in this case. So then you will get a paracavernous variant. Here the vein is actually running on the temporal dura, going well beyond the arcuate eminence, and this is going to drain in the petrosal sinus or transverse sigmoid junction. So I'll take you through this case where we have operated dual aneurysm, ruptured ACOM and unruptured basilar trunk aneurysm with dominant sphenoparietal sinus, and I'll try to show the range of pretemporal transcavernous approach. You can approach anterior intrahemispheric fissure one side and upper pons label on the lower side. So this configuration suited the left-sided approach. Clear delineation of occipitomeningeal band is sacrosanct, and the key is sharp cutting. Now you are having the glimpse of this dominant vein. We have to score temporal dura propria medial to the vein. Removal of the anterior root of the clinoid process, deroofing the optic canal. Now the last part, this optic stress to be removed. All piecemeal. Now you can see the V2, V1, 4th, 3rd, beautiful Dolenz triangle between the 2nd and 3rd nerve. Now you can see this dominant sphenoparietal sinus. So this completes the extradural approach. Now we are coming up with a technique that is known as step 1, 2, 3 of preserving this dominant vein. So step 1, cutting the frontal dura at base. Step 2, temporal dura parallel to the sphenoparietal sinus, going as close as possible to the outer cavernous membrane. Then this third, from the free edge to the optic nerve sheath. Median Sylvian fissure dissection. Beautiful delineation of ACA configuration. And clipping of the ACOM aneurysm. Now just shifting and changing the view. You can see the aneurysm popping out between the 3rd and 4th nerve. Posterior clinoid process was removed. You can see the opposite 3rd nerve, SCL lying below it. Now you understand the configuration of this basilar apex area. Complete mobilization of the 3rd nerve, opening of the liliquest membrane. Now the delineation of PCA is important to understand the configuration of the aneurysm. Now we are dissecting the proximal neck, distal neck, and now you can appreciate the superior cerebellar artery. Now we are good to go to clip this aneurysm after putting proximal control over the perforator free zone of the basilar trunk. So you see the range of this pretemporal transcavernous approach, right from anterior interhemispheric fissure to upper pons, even you can go up to the mid pons. Nice post-op CT scan angiogram showing well-clipped aneurysm. Patient had transient 3rd nerve paresis. One more case of right-sided superior hypophyseal artery aneurysm, you will see almost the same steps what Dr. Kamble has shown, what I have shown in the last video. But the trick is sharp dissection. If you will do that blunt dissection, most of the time you will injure this sphenoparietal sinus. Now you can see this sphenoparietal sinus. Now the same approach. Step 1, step 2, step 3. And then this aneurysm was well clipped. So we have done 49 cases with dominant draining vein, sphenoparietal sinus and superficial middle cerebral vein. Even we have found the cavernous sinus variant as a dominant, most common variant in 67% of cases, followed by the laterocavernous sinus variant in 29% of cases. In 2 cases, we were not able to save this dominant vein, and we had venous ischemia in 1 case. So my take-home message is respecting and saving the venous drainage of the operating area is sacrosanct. And what we are proposing is the step 1, 2, 3 of dural cutting is a useful technique to preserve this dominant sphenoparietal sinus. And we are doing a prospective study with MR venogram to understand more about this mysterious story. Thank you so much for your patience.
Thank you, Dr. Adesh. A fantastic meeting. Thanks for inviting. But though I'm a little angry with the topic you've given, but then I realized why you have given me this topic. So, shall we start the slides? Thanks. So the march to minimalism. So it's been, so I have no financial interest. I've been working with Gamma Knife for 20 years. We have treated more than 7,000 cases. So the patients have a changing perspectives of outcome satisfaction. We have better understood the natural history of benign tumors. Focus has turned over to quality of life from survival. Morbidity is ill-received. Minimalism is a day forward. So what should be the null hypothesis? Gamma knife or SRS is the treatment of choice for benign middle tinea fossa tumors. So is it true? So the gamma knife principle is nothing new. This was the siege of Syracuse by the Romans. Archimedes put in a lot of solar mirrors and all the ships were burnt in the harbor. And the siege continued for 2 years before the Romans were able to break in. So the gamma knife works a similar way. You have 192 beams, non-coplanar beams, which focus onto a central point and gives a very highly focused at the intersecting point dose and low dose at the other trajectories. So just a brief view of how gamma knife differs from SRS is the fact that LINAC has a very larger penumbra compared to the gamma knife penumbra. So if you can see the penumbra of the LINAC on the right is much higher than the penumbra of the gamma knife on the left. Similarly, the extracranial dose of the CyberKnife or the TrueBeam or the Novalis is much higher than the Lexel gamma knife, which transfers to a higher side effect, a poorer profile. So if you compare the extracranial dose of the various radiosurgical machines, the machine which comes closest to the gamma knife is the Zapex. All the others are far inferior to the accuracy of the gamma knife. And also the beam fall-off. Again, gamma knife has the best beam fall-off, followed by the Zapex. So having said that, what is the spectrum of skull-based lesions we will deal with here? Cavernous sinus, hemangiomas, glomas, secondary trigeminal neuralgias, meningiomas, schwannomas, and cavernous sinus lesions. So what are the cases in which you should not be doing gamma knife? You have these large trigeminal schwannomas or clinoidal meningiomas, these clinoidal meningiomas, giant orbital tumors, GH secreting pituitary adenomas, giant invasive pituitary adenomas. You can see the pre and post-op, I will not go into it. Craniopharyngiomas, multi-compartmental craniopharyngiomas. We went a combined transcavernous and anteropetrosal approach for gross total excision. Tuberculum cella meningiomas, cavernopetrotentorial meningioma. All tumors which are quite big should not be given radiation. So that is the first rule of radiation. So what are the ideal indications for gamma knife? So here I will just use gamma knife because I used it, but gamma knife and SRS can be used interchangeably. So these are something. So stage 1 we did this, we were left with this tumor. Stage 2 we did this, then we gave gamma knife. 2 years post gamma knife, the lesion is stable. Or these patients in which a giant petroclavial meningioma, small cavernous sinus residue, gamma knife given, patient is stable. Residual pituitary adenomas, multi-compartmental, you do an extended endoscopic approach, you see the small residual over here, you give gamma knife and post 3 years down the line, it's stable. Giant invasive pituitary adenomas, again a small residual, gamma knife either shrinks or is stable. If the lesion is close to the optic apparatus like this patient, for pituitaries and craniopharyngiomas, it is worthwhile giving IMRT or SRT, where you fractionate the dose for a longer time and you still get very good control. Residual functional GH tumor, though obviously does not appear to be there appear to be any residual, but the GH hormones are on the elevated side, so we gave a gamma knife to the full blood cover. We covered the whole bed and gave a fractionated dose of around 25 grays, and the GH hormone level started coming down. Or this patient in which you can see the differential intensity, what is outside the cavernous sinus has a different intensity to this, so this is going to be hard. So we took out the extra cavernous part and then gave gamma knife to the intracavernous part, stable at 3 years. Or cavernous sinus schwannomas as primary treatment, residual trigeminal schwannomas. So all these are ideal indications for gamma knives. You do surgery for a large tumor, you leave a bit of the tumor, and then you give SRS or gamma knife for the tumors. So what happens in cavernous sinus residuals or primary lesions? So there is no doubt that in spite of the best surgical techniques, the morbidity of surgical techniques are far inferior to primary radiosurgery. And the progression-free survival of these lesions is 97% at 5 years and 87% at 10 years. And some of these patients also have an improvement in cranial nerve functions. So if you see these tumors, primary cavernous tumors, you give gamma knife and they have a very good response. So in this case of tumors, you need to actually think whether it's worthwhile operating this patient, taking a biopsy and then giving gamma knife, or giving upfront gamma knife when you're practically sure about your diagnosis of a benign pathology. So where do we push the boundaries with SRS? So you see this is an elderly patient, probably could be controversial. Many of you could tell, yeah, this should not have been given, this should have been operated. But if you see an 80-year-old patient who has no other deficits but a poor surgical candidate, and you see this type of tumor, and you can see the optic nerve over here, you can see the optic tract and the optic chiasm, and with such a good delineation distance between the tumor and the optic nerve and the patient being asymptomatic for it, I don't think there's any rationale for operating this patient, and we gave gamma knife around 12 grays, 52% isodose line with good long-term control. But where you need actually to be a little more circumspect is this patient. If you can see, we have marked the tumor, we have done an MRI, but if you see, look closely, you see the optic apparatus over here. The green one is where there's a good separation, while the red one, there is no separation at all. So in these cases, if you give SRS, you're actually going to cause increased chance of blindness to the patient. So this, we cancel the surgery and we send the patient for, we cancel gamma knife and send the patient for surgery. Similarly, these patients, if you see a paraclinoidal aneurysm which is compressing upon the optic nerve and the patient presenting with blindness, even though the patient was referred for gamma knife to our center, we still went and operated this patient with good results. Similarly, this patient, a trigeminal schwannoma, a 14 cc tumor, patient well preserved, and you explain the pros and cons and you get very good results with surgery. A 24-year-old medical student, incident detected cranio, wants gamma knife, comes to you. Again, we refuse because you see, even though the tumor is quite small, it's got a large cystic component, it's close to the optic apparatus, and the patient, and it's absolutely reachable through a transnasal route. So these are the patients in which you should not actually give gamma knife. But have the management paradigms changed? So we published this paper on cavernous sinus hemangiomas in 2014, and we were very proud of the results. I mean, you had good results. You could see the ICA. I mean, you saw wonderful videos today. So, but when I analyzed the results of our gamma knife, we found that the tumors were completely disappearing. So these tumors, you see the size pre-gamma knife and post-gamma knife, they almost disappear. And as well as the patient, in many patients, the symptoms have improved. So this got us thinking, and of course, the larger series by the person who actually described the approach. So even in the best of hands, cavernous sinus hemangiomas have a morbidity which is much more than the surgical results, which is much more than the radiosurgical results. And if you see the pooled analysis of all surgical and radiosurgical results, a 64% complication rate was observed after surgical resection alone. Complication rate of radiosurgery was 0.7%. The patients treated with radiosurgery had a 100% decrease in the odds of developing post-treatment complications, and the odds of improvement in symptoms were 5% greater, 5 times greater in radiosurgery. So, so there is no rationale. And if you see one of the largest series of gamma knife for cavernous sinus hemangiomas with volumes from 1 to 84 cc, they have shown that the volume shrinkage is almost 92%. So that means the tumor has shrunk by 92% after gamma knife alone. So for all the students over here, so if you see these tumors, so what happens in meningiomas, what happens in schwannomas, and what happens in cavernous hemangiomas? Cavernous hemangiomas just melt with radiosurgery. Meningiomas do not melt. There might be a 10-20% change, but they remain stable. While neuromas might show a central necrosis, initial increase, which is called a pseudo-progression, and then they start shrinking, but still they do not disappear. So cavernous hemangiomas are probably one group of tumors in which the tumor just melts with radiosurgery. The other group is secondary trigeminal neuralgia. Many of you will be confronted with this problem in your clinic, that a patient with a small tumor comes with trigeminal neuralgia and you wonder what to do. So we analyzed our experience, and it was published in Neurosurgery just 2 months back. And you see that there is a 70 to 80% control of pain as well as tumor growth in patients who have undergone radiosurgery for trigeminal neuralgia secondary to tumors. And this is just with treating the tumor and not the trigeminal neuralgia. People who do radiosurgery will remember that primary trigeminal neuralgia, the dose is much higher, and you give a point dose to the 5th nerve. While here we are actually treating the tumor with 12 to 15 grays to the 50% isodose line. And in spite of that, you get almost 70 to 80% control in pain. And these results are across all series. In secondary trigeminal neuralgia, even there is no role of primary decompressing the tumor, and it's preferable to give radiosurgery. Wait, and if the patient does not improve, then we can go in for surgery. Glomus tumors, again, I think Manjul will do this tomorrow, so I'll not go through this. This is one of the papers published from AIMS by Manish. There is a reduction of around 50 to 70% in size of glomus tumors. And again, glomus tumors shrink significantly with radiosurgery. Similarly, JNAs, this is a large JNA we operated. We did a transfacial approach. This was a residual. We were wondering whether to do it. Then we gave gamma knife, and you see the patient, the tumor just melts. Similarly, this JNA, cavernous sinus residue, you give gamma knife, the tumor decreases. But it's not that gamma knife is very safe. You're dealing with radiation and you need to be very careful about what you're doing. So you need to have a good idea of the volume of the tumor which you're giving. Higher the volume, higher the chance of spillage and higher the complications. You need to know the optic tolerance, optic radiation tolerance dosing. You need to be worried about the temporal lobe and temporal lobe necrosis. You need to be worried about recurrence and failure and radiation-induced side effects. For example, this patient, you see trigeminal schwannoma initially decreased and then increased. This is the doctor with trigeminal schwannoma. We gave gamma knife, the tumor almost decreased, and then this patient came with increase again, and then he had to be operated. So failures do occur, but you need to remember that gamma knife almost has around 90 to 95% success rate in tumor control. The other problem is indiscriminate usage of SRS, especially by radiation oncologists, who basically have no idea what they're doing. So this patient with a meningioma came to the OPD a few weeks back and was given almost 30 grays, and this was the result. So you see the edema and the frontal lobe edema and the tumor necrosis. So these are some things which you need to avoid. So when to use, last two slides, when to use gamma knife? You need to remember that as the size of the target lesion increases, the incidental irradiation to the surrounding normal tissue increases. It is generally, as a rule of the thumb, we do not recommend SRS for lesions greater than 3 centimeters because of radiation toxicity. But we also have given gamma knife for benign lesions, including chordomas and chondrosarcomas. With the advent of the ICON, the fractionated RT and SRS should be considered. SRS generally avoided the maximal dose, and also the location of lesion is important. So this is the last slide. So the elephant in the room is, will SRS gamma knife replace microsurgery, or will the radiation oncologist make surgery obsolete? I think the answer is no, but they're definitely pushing off boundaries, and what we were taught when we were young probably holds no longer good. Surgery definitely is a better option for convexity tumors, when it's close relation to the optic apparatus and the optic dose radiation, or close relation to the brainstem and you cannot get the tolerance limits, or when the diagnosis is in doubt. But as of today, for cavernous sinus hemangiomas, glomus, secondary trigeminal neuralgia, any primary benign tumor less than 10 cc and residual tumors, SRS or gamma knife has to be the treatment of choice. There is a relative gray zone of around 10 to 14 cc, which the decision can go either way. But apart from that, the indications are clear-cut. And in fact, in our center, the surgery for glomus and cavernous sinus hemangiomas has come down significantly. The other important thing to note is the relation to vital structures, and probably might have to fractionate the dose. So I think stop here. Thank you.
Thank you, Dwarkanath. This is the last topic of this session. I'll invite my co-person, co-chairperson, Subhas Konar from Bangalore, on his panel debate on diagnostic dilemma in middle cranial fossa.
So thank you, Adesh and Amit sir, for giving the opportunity to present. What Adesh told me that you present some few cases, and then where will be there is a like what sir presented, diagnosis in doubt. So diagnostic dilemma and the management in middle cranial fossa lesion. So I'll be covering a few rare cases. The first group cases, 3 different types I'll be presenting. So case 1, a 25-year-old man presented with headache over the temporal region and giddiness, no history of fever or weight loss. On examination, conscious obeying, no cranial nerve deficit, no motor sensory deficit. This is the scan. This is a right side temporal pole, 1 lesion in T2. It is hypo with significant edema. On contrast, is enhancing. T2W scan. You can see right side, it is a hypointense with edema. So this is the contrast scan. So it is an enhancing lesion with a dural tail, with lateral orbital wall is also involved. So this patient underwent temporal craniotomy and excision of the lesion. So for the resident, what will be the diagnosis? First diagnosis, and what will be the differential diagnosis? Yeah, Manjul. Okay, I'll keep fungus 1 DD. Yeah, it's hypointense. Even sulcus meningioma also, if more fibrous, it will be hypo. Yeah, edema is there, skull-based secretory type, sometimes they will have, but I'll keep the DD as a fungal. Any other DD? So I'll go the same pathology, 3 lesions. This is the post-op scan, we have removed cross-total section. The second case, a 45 years old lady, female, presented with right side facial pain for last 6 month duration. Only deficit is like maxillary division, right side, 25% sensory loss, no motor, no cerebral deficit. This is the scan. It's a tentorial lesion with middle cranial fossa and posterior fossa extension, right side. So this is the lesion. So what will be the differential diagnosis?
There is the multiple lesions.
Meningioma. First DD is meningioma. Okay. Yeah. So you'll keep, if it is a meningioma, it will be a multiple meningioma. Sir, Mike, can you take? Mike. 45, sir. With facial pain.
Check.
So we did surgery, MCA-based approach, we decompressed the Meckel's part, patient improved.
IgG4?
Yes,
IgG4?
Yes, sir, one.
Subhash?
Yes, sir.
IgG4?
One of the DD. Okay. So this is the last case. So I'm just going from simple to more complex. This is a 23 years old man. Sir, I'll tell you, sir. All 3 cases are same diagnosis, so I'm just. So 22 years old man presented with visual loss for 3 months, headache, conscious obeying, visual acuity right side 6/60, left side 6/9. Fundus shows early optic atrophy, no other deficit. I'll go to directly contrast. So this is the scan.
तुमने तो decision दे दिया. All three having same diagnosis, histiocytosis.
All 3 are Rossi Hoffman.
Sir, all 3 are
neurosarcoidosis.
Rossi-Hoffman diagnosis. So why diagnosis is important for the resident, that always we should keep that it is not meningioma, because the second case is classically looks like meningioma. The third case is more like, even the second case has a multiple multicentric lesion. So now my question is to our experts that what we should do. We should go for GTR. We should just restrict ourselves to biopsy. And what next? Is the diagnosis is Rossi-Hoffman disease?
So what happened, most of this Rossi Hoffman will have some lesions in the sinus. So we can take a biopsy of the sinus endoscopically and establish diagnosis.
Like we have a series that all will not have, sir. I've just covered because others told only to show MCF base.
All will
not mandatory,
have,
sir.
No, all will not have sinus
all
disease.
not have. I have a systemic review also, sir.
They respond also to steroids.
Yes,
but
sir.
if there is a mass, you still need to take it out. That the tumor mass is to be removed, and then you give steroids, and then you follow. But they come back, unfortunately. This Rossi-Hoffman is a very difficult disease to treat, especially this kind of thing is very difficult
Yes,
to
sir,
treat.
difficult.
He will keep on coming back, whatever you do. That's the problem. The last is, of course, radiation has been also tried. But if the patient is not symptomatic, we have a number of cases now which we're just monitoring, course of steroids, stable disease we're monitoring. But there is, the literature also says that you can give radiation, but bulk of the disease, if the patient is presenting the mass effect, we decompress it.
Yes, so that what
And
said told.
all our patients, in fact, none of them have sinus. None of them have sinus.
I agree. But Subhash, if you had shown the T2 images, actually the T2 images are a good clue for differentiating between meningiomas and Rossi-Hoffman.
Sir,
Most of the chronic inflammatory,
T-
whether Rossi-Hoffman or IG4, are actually hypo on T2.
Sir,
While meningioma
all are hypo. I agree with that. That granulomatous we have to keep first DD, but sometimes skull base with fibrosis, sir, there will be a T2 hypo. That's a point, sir, for the resident. IgG4, where there will be a delayed contrast enhancement. Like if you do a delayed contrast scan, in that case there will be an enhancement will be delayed in IgG4.
No.
So these are Rossi-Hoffman is.
IgG4 will not have a like globular. They have more like N block. They don't put.
Sir,
mass
we
in
have our in Niman, sir, like insular RDD, we have parenchymal RDD. Like I just covered the MCF base. We have orbital RDD. So I'll show you that. So what are the DD like? Closest radiological DD is meningioma, and the Langerhans cell, it is like Langerhans one group, non-Langerhans. Non-Langerhans first is RDD, second most common is Erdem-Chesler disease or IgG4. Now it is coming. These are the DD of this case. So literature review wise, what I found, it can involve the CNS or it can be a systematic. Systematic with CNS involvement is 17%. It can involve skull base, convexity, parasagittal, brain parenchyma, including spine. We have 2 cases of extradural spine lesion of RDD. Intracranial lesion, commonly 70% cases there will be no lymphadenopathy. So always if you are suspecting, then we have to look for cervical lymphadenopathy in this type, if you are suspecting of RDD. And no associated systemic symptoms in CNS is 52% cases. So what I found in literature, more than 300 cases reported, intracranial is almost 80%, spine is 11%. And this is our Nieman's series of 39 cases where cranial nerve deficit is 24% cases. So you can see that how close it's with meningioma, because they looks like meningioma, so they are like a meningioma mimickers. And imaging wise, T2, T1 will be iso intense, T2 will be iso to hypo, strong hypo intense within iso like typical granulomatous lesion, and the other is like there will be a dural tail like same as meningioma. And FDG PET has very good diagnostic value for systemic evaluation, detection of recurrence, and what Sir told, commonly we'll treat with steroids, so that lesions are stable or not, we can do FDG PET and in doubtful intracranial cases.
This is hypermetabolic or what? These are hypermetabolic? Yes. Okay. Which meningioma will not be? So
yes,
that
sir. Sarcoidosis is one of like granulomatous lesion. Sarcoidosis only in paracellular cellular lesion. And you can do ACET serum values. No, these are, sir, if recurrence or stabilization of already diagnosed cases. So we have done here 32 cases and craniotomy 2 GTR and then transpenoidal biopsy also done, only biopsy. Sir told like radiation also, IMRT also tried, low dose like GKR is also given. And what the most important is the treatment is steroid. This is like a chemotherapy, anti-CD20, the neurologists they tried. Once we got the diagnosis, we referred. And this is like, it is almost like stable. This type of lesion, we cannot do complete.
What chemotherapy?
So anti-CD20.
Immunotherapies and all are coming, MEK inhibitors, anti-CD, yeah, all these are coming in.
So it's just to stabilize
the main thing is what I have seen is, I've operated 2 or 3 of them, one reported, one was bilateral. Yeah, so what I've seen is they have a lot of cavernous sinus, the ones involving skull base, a lot of cavernous sinus, middle skull base. The involvement will be like meningioma, but if meningioma is in a similar position, will have much more cranial nerve paresis. But an in-plaque in the central skull base will have much more cranial nerve paresis than this. Yeah.
So it can be solitary, biopsy, chemotherapy, radiation, steroid is the most important. One more lesion I wanted to just present. A 35 years old man presented with headache for 6 months, right side facial pain for 2 months, no other comorbidity, and conscious obeying, right mandibular division, mild sensory loss. So the lesion source, right one MCF based lesion with T2 hypo. I'll go to the contrast.
T2? We have a T2?
Sir?
T2?
T2 and so on, sir. It is T2 hypo, sir. I'll show you.
Fungal aspergillosis.
It's aspergilloma.
Aspergilloma.
Yes, sir.
So the granulomas will all have sinus.
Yes, sir.
That may be one of the differences.
That's why I kept like after RDD, that next is granuloma. So you have to look for the sinus. So what sir told, all cases will, RDT will not have sinus involvement.
What was it? It's a very large series.
Sir?
The response to radiation,
Sir,
you know.
best response with steroids, sir.
No, but you had some cases with radiation. What happened to those
Sir,
cases?
it is stabilized, like, they are all
You
on
publish
follow-up.
this? You have published?
Yes, sir, we published.
Published recently.
Yes.
3-4 months.
What is the feel of this RDD during surgery? I mean, did you have any inkling during surgery that it was something else other than meningioma?
It doesn't look like meningioma. It is like a rubbery, sir. Like that eraser that we used to have in pencil eraser. It's typical that spongy and rubbery. And CUSA also. CUSA goes in. It doesn't destroy it. It goes in and comes out. You create punches, and then you have to take scissors and cut those punches. That's what my three cases experience. I found that.
So I think there's only. So I think for the residents, the learning thing is whenever you see a lesion which mimics a meningioma, but is very hypo on T2, then you need to have a high grade index of suspicion that it is going to be a granulomatous lesion. So once you have this suspicion, then you inspect the sinus. So if the sinus is involved, then you have to suspect a fungal lesion also.
I will like to, excuse me, I will like to give you my experience on.
So like, it's a aspergilloma fungal, sir.
I will like to give you my experience with aspergillomas. You know, aspergillomas, as you rightly said, can be a diagnostic dilemma. And you might go for a meningioma and you think that it is a meningioma because it resembles a meningioma. And you try to resect it as radically as possible. Now, I have reported 4 cases in the literature where I resected radically. The patient was all right after surgery, and after 2 or 3 days developed dense hemiplegia.
Vascular involvement.
Now, why he has developed dense hemiplegia is the question mark. Now, in one of these 4 cases which I have reported, 3 of skull base, 1 of cerebral, we did postmortem examination in the basilar artery, which I showed in my paper. There were aspergillus, the organism. So we have to remember this. Aspergillus, if we have a diagnosis of aspergilloma, we may like to limit our surgery, that is one. Second thing is why they develop this kind of deficit after surgery is the big issue, because they were all right before and now they have developed. So we related in my article, we said that giving of steroids, too much steroids can be a negative kind of a factor. Like you said, steroids can be given. So we should avoid giving steroids when there is a suspicion.
We are treating with voriconazole, sir, till the clinical improvement of the patient, like neurologist. There's not radiological follow-up, it's the clinical follow-up. Even in this case also, sir, we went and then there is a, we have removed, but there
even
is a
after
PCA.
radical excision,
Yes, sir.
voriconazole, as per the mycologist, has to be given for 6 months. There is no trace of anything seen.
Sir.
Patient is fine, but even then the mycologist would say, please give voriconazole for 6 months and also check the level of voriconazole. The institutes have got the facilities to check the level of voriconazole.
I think radical excision is not warranted.
So this is an infection, so this has to be treated by infection.
Yes,
But
sir.
I think aspergilloma, I mean, we have some cases of aspergilloma, not very large series, but I think at the operation they are different because they don't bleed. They're avascular lesions as compared to.
They're very hard.
They're
They're
very
hard.
firm, or sometimes you have to cut it, but they're not vascular. And of course, I mean, you have to give like Dr. Pathak said, the levels are very important. You need to monitor
Yes,
the levels.
yes.
And the infectious disease has to take care of that. Sometimes we have a case which is 1 year he took. So it's not that 6 months course, minimum 6 months course. That is what it is.
I have one case where there is no trace of infection in the sinuses, but yet it turned out to be large meningioma, what they thought.
It's an infectious disease.
Yes,
No, it's like
and
TB.
this patient was level. They gave a brand, the cheaper brand. The levels didn't come up. Then you go to a brand which was 3 times the cost of the cheaper brand, and the levels came up. So there's a problem in that also. Just giving voriconazole.
Lyophilized.
Yeah, I mean,
Lyophilized
whatever it
voriconazole.
is, I mean.
What I remember from literature is that radical resection is not warranted because these are angio-invasive.
No, again, it's same thing like
Yeah.
Dr. B.K. Mishra. never knew that it was a aspergilloma. I removed it completely, very happy. And then you may surprise, this is fungus.
So the problem is, like Dr. Goyal said, even with me, 50% of my patients died within a week with massive influx.
Fortunately, mine didn't die, so that's I'm lucky.
Massive infarct because you have gone to the cavernous sinus, because you have gone to the vessels.
No, sir.
You have been always down, so that you have reached there.
No.
Stay away from the vessels. You don't have
But sir, I think even if you open a subarachnoid space in a fungal lesion, you are bound to have an angio invasion over there. And if we suspect it intraoperatively that probably we are dealing with a fungus, during surgery only we give a loading dose of voriconazole to those patients.
No, there is a guy from Punjab, I don't know, from Chandigarh somewhere, he has got a very large,
Dr.
a very large series, no?
He has close to around now 700 patients because that area is
very large series got his.
He's in PJ, sir.
Okay, right.
Yeah. He's Professor PJ.
I think it's a nice discussion for this. We'll go to the next session. We're not taking up any questions for this session. Thank you.
Thank you. Thank you.
So, starting with the last session for the day, that is free paper presentation. I request all to stay in the hall as shortly we'll be starting with the last session, that is free paper presentation. I request all the presenters for the next session to please be ready with their presentations at the preview desk.
Okay, sir. मेरा नाम पता है ना? प्रज्ञान. It's our pleasure. Dr. Pragyan is here. मैं सुबह 3 बजे से एयरपोर्ट में बैठा हूँ. प्रज्ञान का टॉक क्या है? वो स्टार्ट 2 बजे का. टाइमर खाली बोल देना 10 मिनट है. 5 मिनट बाद करना. संजय बिहारी की बात है. 3 बजे का. I request all to please come back to the hall as we are starting with the last session for the day. May I call upon the moderator for the last session, Dr. Jayesh Sardara. I call upon the stage the honorary chairpersons for the session, Dr. Akshay Patil and Dr. Ramakrishnan Ishwaran. I request all to please come back to the hall as we are starting with the last session for the day.
Respected faculty members and delegates, please take your seats. So, respected faculty members and dear delegates, Dr. Pragyan Sharma has reached. His flight was delayed. So, he was a speaker in our vascular skull-based neurosurgery session. He's been up and has taken a lot of effort. So, I request you all to please take your seats.
And we'll start with Dr. Pragyan Sharma, managing the vascular injuries associated with the skull base approach.
Yeah, so
all delegates, please come inside hall.
Yeah, please adjust the timer, it's 10 minutes. Yeah, so good evening everyone, and sincere thanks to the organizing team and also Dr. Adesh for the opportunity to speak. So we have already had a wonderful day, wonderful talks, and it is not always a gratifying experience to talk about your complications, but that's what I'll be doing for this talk because that's where we learn from. So no disclosures. Now, if we talk about vascular surgeries, vascular injuries during the skull base procedure, they can present it in a wide gamut of basket for us. It may be arterial, it may be venous, it may be immediate, it may be delayed. However, in the interest of time, and I will be mostly dealing with ICA injuries in the endoscopic and skull base approaches because that's what is the most scariest part for a surgeon during the course of surgery. Now, I'm sure all of you have come across these kind of tumors. This is a chordoma, which is displacing the bilateral internal carotid arteries. And this is again a giant pituitary adenoma, which is encasing and invading the internal carotid artery. And particularly for these cases, one has to be very meticulous in the surgical technique to avoid injuries. because if you are not very careful, this is what happens. As you can see, this is one of my cases, which unfortunately, during the tumor decompression, I ended up rupturing the ICA. So now, how to prepare for it? First of all, we need before the surgery, one need to be very meticulous in the surgical planning. It's imperative. It's very important that you go through all the MRI and CT scans, and especially if you encounter this kind of findings in the MRI, pre-op MRI, one has to be very careful. Tumor histology is of course important. Some tumors are very fibrous, like chondroma and chondrosarcoma. Tumors undergoing radiotherapy and those which have undergone bromocriptine therapy are fibrous and therefore are more prone to injure the internal carotid artery. Finally, if you are going out with an aim to radically excise the tumor and the tumor is totally excising the ICA, again it is a risk factor. However, as a surgeon, we must be aware of the surgical anatomy around the sella for endoscopic approaches, and this slide nicely depicts the various vascular structures in their normal position, and as a surgeon, we should be well versed with the position of the vessels and the name of the vessels. I'm not going to intricate details. Saying that, prevention is always better than cure, and the same applies to the skull-base vascular injuries as well. We must know that the tumors may present to us with a different kind of findings. They may invade the ICA, they may encase the ICA, they may encapsulate the ICA. However, the nature has given us certain important landmarks which we should be well versed with, and these are the different landmarks of the ICA for different segments. One should be very well versed, and it's not difficult to make it out during the course of the surgery if you are quite putting up the effort. So this was the first case, which was a planum spheloidini meningioma. As you can see, the tumor is laterally encasing the ICA. So I'm skipping the initial part of the video. So yeah, after the cellular exposure, you need to go to the paracellular area, this area, because tumor is extending laterally. And we are very careful while drilling. We are going into the paracellular exposure. So the use of rongers, one has to be very careful because the direction of the ronger has to be parallel to the bone edge, not perpendicular. However, despite that, while removing the bone, with copious irrigation, as you will see now, I ended up causing a vascular injury. Initially, I thought it's a major ICA injury. However, it was not so. So the field was made clear initially. Then the teamwork is very important. Since it was not exactly an ICA tear, rather a branch tear, initially I tried to coagulate with low setting with copious irrigation, and ultimately succeeded. And it was supplemented with Procil. As you can see, it is then the tumor excision was continued. I'm not going into the detailed steps. So for meningiomas, it's very important that we dissect in the subarachnoid plane. Once you are encountering the chiasma, just posteriorly is the ACOM complex. So here you can see the ACOM complex is gradually coming into view. So this is the subarachnoid plane. We have continued the dissection, but while removing the tumor, again there was a vascular injury. As you can see, I was going into subcutaneous plane, but there was again an injury. So this time initially I thought again some major vessel, so I tried to initially slight coagulation, didn't succeed. Tried to clip it, again didn't succeed. And ultimately it was controlled with bipolar. And this is a tumor excision which was continued. And finally this rim of the tumor, which was quite adherent to the vessel, was left behind. The post-op scan, of course, we saw some residue. It was imported to a DSA. In the DSA, we saw there is significant spasm, and there was ipsilateral absence of the ophthalmic artery. Patient had visual deficit, but he recovered well. This was another case where we had ICA injury quite early during the course of the procedure, during the opening of the dura itself. You will see now. And yes, and then again, it's important not to get panicky. Teamwork is important. Field was cleared. The suction pressure was increased. The tear in the ICA was identified this time. It was a major tear. However, it was controlled with muscle packing and flow seal. So DSA, of course, showed some leak, as you can see. Ultimately, the case underwent covered stent placement. So there was significant residue, and the patient was again taken up for open surgery after 4 weeks. Now, this was an important paper published by Professor Atul Goyal way back in 2000, but in the present context, this paper is again very important. He describes certain characteristics of the tumor like encasement, tumor size, and also the visual status of the patient, and depending upon that, devised a scoring system through which we can decide whether the tumor is gross totally excisable or not excisable. So it is important that we have proximal and distal control in this kind of tumors. This was again one of my cases where there was ICA. This was a very previously operated case of chondrosarcoma, in fact. Tumor was very fibrous, and I had injury, ICA injury, which was controlled with covered stent because we have endovascular backup in our department as well. So what I'm trying to emphasize is during the course of vascular injury, it is very important to have proximal control if possible, and in certain tumors, it is not a bad idea to do the neck draping. Again, this was one of the cases which was a giant chondrosarcoma again, so it was very fibrous, going fast. So yeah, so this is the drilling, ACP drilling was done. This is the whole fibrous tumor. It was not excised to piecemeal excise it. Piecemeal excision was not possible because the CUSA was not working. And finally, while trying to remove the tumor, again, as you can see, there was blood kept pouring in and there was injury. So ultimately, we decided to pack it, and it took a significant amount of time. But in the post-op period, as you can see, there is significant spasm and stenosis of the ICA, and this patient developed ICA infarct in a 7th day, and we couldn't save him. This is the final case. Again, there is a giant tumor, which was quite adherent to the vessel. This is the MCA, ICA, and as you can see, the tumor is grossly adherent. We tried our level best to remove the tumor, dissect out the vessels, but it was not possible because it was significantly adhered, and therefore ultimately it was decided to leave a rim of the vessel. So this is the post-op scan. The scan was not very promising because there was a residue, but this part of the tumor was excised and patient had excellent outcome. This was again a tumor, meningioma invading the optic sheet, where after proper exposure, adequate exposure in these kind of cases are very important. While cutting the optic sheet, which injured the aberrant origin of the ophthalmic artery, which you did not anticipate, but it was well controlled. It was a minor tear and well controlled with Flocil and packing. So these are the various principles of controlling the vascular injury. You have to have vascular control, followed by vascular reconstruction. There are different methods that are applicable. Primary repair often is not successful, and it is very important to have endovascular backup whenever possible. Nowadays, there are so many hardwares available that most of the ICA injuries can be handled with optimum results. So these are some of the surgical tips which helps us to prevent injury of the ICA during the course of surgery. Use of diamond bars is always advisable, and whenever possible, one should be very careful in using the rongers. So these are the principles which I have already described in my videos. The different principles of sacrifice of the vessel. We can undergo bypass in selected scenarios, and of course, vessel preservation techniques can also be undertaken. So navigation, as we all know, is very important. However, we often forget that in setups where the navigation is not available, even SSCP and EEG can provide some surrogate information for BTO in the setting of an intraoperative injury. So these are the various literature. You can go through it. There are lots of literature available for the management. Finally, irrespective of whatever be the cause, it is very important to come back to the drawing room to analyze your pre-op videos and to analyze the root cause, what might have caused it, to learn it, and to implement it for further future cases so that it can be avoided. To summarize, yes, major vascular injury can occur. Often, if you have done meticulous planning, these are not major vessel injuries. Most of them can be managed with teamwork, and endovascular backup whenever available often helps. Ladies and gentlemen, I would like to end this presentation with a famous quote, which says, "It is your reaction to adversity and not adversity itself that determines how your life's story will develop." Thank you for your patient hearing.
Any question or comment? So Dr. Pragyan, the 3 cases you have shown of IC injury, all 3 cases you have shown of IC injury, what did you done? You done a stenting, all the cases?
Pardon?
IC injury cases, post-op, what you have done?
Most I have done covered stent, basically. Wherever the ICA, because wherever there is significant stenosis or there was continuous leaking, so the protocol is to repeat the DSA if there is no significant leaking. Even then, we have to repeat the DSA after 4 weeks. It is very important to repeat the DSA even if the first DSA is normal. And if the patient is hemodynamically not stable, it is still bleeding, of course, placement of a covered stent is advisable.
Fine, thank you.
Thank you.
Dr. Pragyan, last case you have shown that ophthalmic artery injury, correct?
Yeah.
So what?
Patient had visual deficit.
That's what I'm asking. Is there any deficit post
Yeah,
op?
yeah. Patient had
because you
visual
have controlled. You said you controlled bleeding and everything was okay.
Yeah, so in the DSA, I could not show due to lack of time. When DSA, their ophthalmic artery could not be visualized, and patient ended up with ipsilateral blindness.
Thank you, Dr. Pragyan.
Thank you.
We will go on to the next session. This is actually part of the previous session. The first talk will be by Brajesh Kumar. He'll be talking on intracranial tumor mimicking meningioma. You already saw some from Subhash Konar.
I will be presenting on intracranial tumor mimicking meningioma.
Speak into the mic, please.
Meningioma mimics in the literature are the neoplastic, like the metastasis, solitary fibrous tumor, melanocytic tumors, glioblastoma, Epstein-Barr virus associated smooth muscle tumors. Other granulomatous lesion like tuberculosis, granulomatosis with polyingitis, sarcoidosis, then proliferative disorders like lymphoma, basal Dorfman disease, and autoimmune disease like IgG4 diseases. My first case is left glenoidal lesion. It is was a 40-year-old young woman who presented with in our OPD with decreased vision in the left eye. There was no other complaints. She had no focal deficit on examination. Visual acuity was 1/60 in the left, and the patient was having diabetes mellitus in the during a time of admission. She was diagnosed with that. Now coming to radiology, this case has already been discussed previously by Dr. Kunar sir. This MRI showed the enhancement in the T1, then T2 shows the hypointensity. Now the operative pictures after opening the sylvian fissure, we can see the lesion. The intraoperative, it was non-vascular and almost like not firm like a rubbery lesion. It was encasing the ICA, the optic nerve. So slowly we started with the CUSA, and the tumor was separated from the this optic nerve, and the third nerve was freed, and we could not. I left the some amount on the carotid bifurcation. A small remnant we can see over the carotid bifurcation. And this is the completion of surgery. And the histopathological diagnosis was aspergillus. In the both the H&E and the GMS stain, both show the aspergillus. Second case is that posterior foci as well. She was a 22-year-old female admitted with headache and vomiting and imbalance on walking, operated in 2023, and it was, we suspected atypical meningioma. We can see the hyperintense lesion enhancing lesion on the T1. And this CT showed the bony spicules in the tumor. And this is the post-operative CT which shows complete removal. And same patient was readmitted with headache, vomiting, and altered consciousness in 2025. And now we can see the this MRI showing the bony involvement invading the cerebellar parenchyma. And the histopathology and immunohistochemistry showed mesenchymal chondrosarcoma. Other reported cases like cat scratch diseases, then metastatic breast cancer, then some reported as Ewing sarcoma, as a the parasite and meningioma. Thank you.
Thank you. We finished on time. I think fungal granuloma was rather expected from the discussion that went on last time. Can you tell me how this, hello? I'm asking you a question. Did you review the histology of the previous occasion for that patient who turned out to be mesenchymal chondrosarcoma? Because I suspect that the first tumor was also the same thing. Correct. It was reported as meningioma, but if you look back at the histology, probably they would say that it is also a mesenchymal chondrosarcoma.
Followed the histology, sir. Actually, we thought it's a clear case of meningioma, so we did not follow that slides and other.
Right.
So I'll ask next person to come on the desk to present his work. How useful is the preoperative embolization in cases of sphenoiding meningioma? Suyash Singh.
The next speaker can take up his position here so that we save time.
Good evening. So whether a neurosurgeon is doing surgery, mountaining or gliding, safety planning remains the most important factor. So as the technology is advancing, gutter gears and automatic advancement systems are coming in the paragliding also, and the technically important ropes are coming. Similarly, while we are doing surgeries in skull-based tumors, pre-operating planning with the embolization remains the most useful thing. So definitely, if the outcome is beautiful, the surgical planning remains the utmost important. So with the popularity of an objective assessment index, that is meningioma vascularity index, where the volume of flow voids is automatically calculated in millimeter cube by the software based on number of voxels selected and manually converted to the cubic centimeters, we can ascertain the objective parametric of whether a meningioma, how vascular is. And depending upon the vascularity index, we can plan whether the preoperative embolization is useful or not. So embolization remains a new adjuvant to our technical skills of neurosurgeon. It is the treatment option, but for minority of tumors. Meningiomas are commonly supplied by various vessels, but why embolization is important? Not only because it devascularizes the meningioma, but it changes the tumor characteristics also, increases the likelihood of gross total resection and minimizes the operative morbidity. So it decreases operative duration, reduces operative blood loss and alteration in tumor consistency. There are various papers which shows that histopathology of an embolized meningioma has small cells with high NC ratios, cytoplasmic vacuoles and intercerebral discohesions. The tumor cells have changed the Chi-67 index, and the tumor cells were located around the feeding vessels but disappeared from the far vessels. So there are literature initially in 2014 and 15s were disfavoring the role of preoperative embolization, but actually in these papers, they were covering the whole meningiomas as surface meningiomas and skull-based meningiomas. And in these papers also, the skull-based location was found to be statistically significant. Although the overall result was that embolization was not an independent predictor of gross total excision. But certain guidelines were given in 2014 and 15 review or meta-analysis also, which says that large tumors with at least 50% of the supply to the tumor originating from accessible branches, and the tumors which appear hypervascular or with a meningioma vascularity index more than 5 actually suggest that preoperative embolization is useful. Later on, in 2019 and 18, the repeat meta-analysis was done focusing on skull-based meningiomas, which says that preoperative embolization is an effective neoadjuvant intervention prior to resection. The resection of skull-based meningiomas without preoperative embolization affords complete resection rates of 47 to 81%, whereas in embolization portion, the resection rates were more than 70%, with a complication, major and minor, being the 6% and 0.2%. Among all the skull-based meningiomas, sphenoid wing meningiomas remains a special. The surgical management of sphenoid wing meningiomas is challenging, especially when they are invading the cavernous sinus, internal carotid artery, and visual pathway. Most of the medial sphenoid wing meningiomas have dual blood supply. The optimal timing of surgery following embolization actually varies depending upon the embolizing agent used. The proton spectroscopy shows a maximum peak of broad aliphatic signals at the 4th day of embolization, and that is why we usually do surgeries on the 4th or 5th day. This observation was used to determine the optimum timing of surgery after tumor embolization. Meningioma embolized with PV particles softened after 7 to 9 days. The rate of recurrences for medial sphenoid wing meningiomas is regarded as the highest among the intracranial meningiomas. So there are studies which says that 7.7% was the recurrence rate in group 1 tumors, and the 27.5% in which the tumors were not embolized. Similarly, in Indian literature also, the Podal et al. Concluded that achievement of gross total resection of 100% in the embolized groups. So, but the partial embolization will not be helpful in these tumors. There is a questionable benefit to incomplete devascularization of these tumors. Only complete embolization of meningiomas result in decreased blood loss. So that is why I said that selective patient selection is most important while going for preoperative embolization. Patients with partially devascularized tumors had a 3-fold greater risk of requiring transfusion during open surgeries than those with completely devascularized tumors. In tumors with both ICA and ECA supply, embolization of just ECA feeders was effective in only 26.5% of the tumors. So there are various literature which suggest that after embolization, either using PV particles or onyx, the success rate is more than 90%. There are various particles which are used for embolization. They can be particle embolizates like PV alcohol particles expand the aqueous solution and produces an inflammatory response resulting in thrombosis of vessels and making PV an efficient embolic agent. The deeper penetration into the tumor vessels bed can block the venous outflow and lead to hemorrhage. But we are using the glue particles and especially the acrylates considering the financial constraints and availabilities. In the acrylates can deliver both a broader range of microcatheters which allows for better distal navigation compared to particle agents and can enter feeding vessels simultaneously and can be administered with a lower injection pressures. Whereas the liquid embolizates like onyx has gained popularity for success with embolization of AVMs. The slower precipitation of the onyx confers the advantage over the liquid agents because it can permeate deeper within the tumors. So again, now in the 2025 and 24, the papers are coming up with the preoperative embolization being the better option. Because we are in skull-based tumors, I am ending my presentation with foramen of Vesalius. Preoperative tumor embolization via FV results in disappearance of the tumor stain. This is the new foramen between the foramen ovale and rotundum, through which emissary veins passes and communicate cavernous sinus and pterygoid plexus. So nowadays we are using these foramen for complete embolization of meningiomas. Thank you so much.
Anyone else uses embolization? Dr. Mishra said he does not. Anyone else for it? Seems to be few takers. Thank you.
So next up, Dr. Bhagat Singh, avoidance of complication in endonasal pituitary surgery.
Good evening to everybody. First of all, I thank AIMS Bhopal for this opportunity, especially Adesh. And my topic is avoidance of complication in the pituitary surgery. From the beginning itself, so many talk about the various pathology ranging from micro, macro, secreting and non-secreting adenomas, and wide variety of options, observation, medical management, and up to radiosurgery. So there is always a complication in the surgery. So how to avoid the complication? This is a show about the micro and macro adenomas. More than 10 millimeter considered to be the macro adenomas, and gained adenomas and invasive adenomas are another classification that involve nearby structures. So various approaches, transsphenoidal endoscopic is a mainly thing I want to discuss. Endonasal and extended endonasal. In the endonasal, uninostril and binostril technique, and various other added procedures are there. How to avoid the complication in pituitary surgery in these approaches. So my experience may be some more added. For the past 15 years, I am operating on it, associated with the ANT surgeon. So pituitary surrounding structures, all internal carotid artery, cavernous sinus, everybody talk more about it, and how to avoid this during this kind of pituitary surgery. So standard approach is uninostril, binostril technique, and usually for the uninostril technique, simple adenoma, it's non-invasive and non-gained adenomas, and other thing mostly of a binostril technique with forehand one. So nasal phase, sphenoidal phase, cellular phase, pituitary and cavernous phase, and skull base reconstruction. These are the 5 phases. The nasal phase, most of them tell about that post-operative complications, and sphenoidal phase and cellular phase have an exposure thing, and pituitary and cavernous sinus, the removal of the tumor, the residual is considered as a complication, and skull base reconstruction is an important thing, extended skull base approaches. So endoscopic anatomy importance, cadaveric dissection is an important tool, principles of surgical approaches, and institutional experience. So anatomy is the destiny. The nasal septum, turbinate, sphenoethmoidal recess, sphenoid ostium, sphenoid sinus, and floor of the sella, and finally the meninges. These are the bony landmarks. So certain important problems in the nasal phases. Cribriform plate is important. The less than 1 centimeter in the lower roof of the ethmoidal cavity, very thin pore, rare. Care must be taken during the handling of the endoscope. Sphenoid sinus, ostium. So this is a video, I skip it, nasal and sphenoidal phase. So once reach the sella, the anatomical landmarks are important. So various added things like a navigation, Doppler, and up to intraoperative MRI is useful for the complete resection of the tumor without residual. So scala, the normal size sella, the cavernous carotid artery separated by 13 to 17 millimeter. The medial extent of the ICA and the lateral surface of the pituitary gland is just 2 millimeters separated. So meninges differences sometimes cause a problem in opening up the cavernous sinus or ICA. The last presenter nicely saw about the various ICA injuries. So this is about the sphenoidal phase. This also I skip it. So again reconstruction, just 2 minutes. So reconstruction is very important after the total removal to avoid the complication, all the complications of postoperative CSF leak that cause the total loss of surgery without the benefit of the endoscopic approach. So non-invasive pituitary macroadenomas, endonasal sphenoidal approach, able to remove the tumor with all corridors. The skull base repaired with adequate measure to avoid the CSF leak and its complications. And come to the gained and pituitary adenomas, the extended skull base approach, and again anatomy is important. The sphenoid sinus is the central location, and extension into the lateral and the anteroposterior areas should be considered according to the epicenter and extent of the lesion. So all the things should be considered into the preoperative evaluation, and whatever the procedure we have to plan should be take care. The gain pituitary adenomas, 5 to 14% of all pituitary adenomas. The size is more than 40 millimeter in any direction and less than 6 millimeter from the foramen Monroe, and more than 30 millimeter above the tuberculum cella, multi-directional spread, more direction and more et al. Described in 1990, more than 40 millimeter from the midpoint of the jugum sphenoid is considered as a gain pituitary. The gain pituitary adenoma gross total reduction is life-saving, vision-saving, and pituitary and hypothalamus saving. Subtotal excision is not a choice. It's a life-threatening post-operative pituitary apoplexy and required transcranial surgery or repeat surgery within the same night. So invasive pituitary adenoma, when come into it involves the bone sphenoid sinus. Invasive does not include the supracellular extension. The cavernous sinus invasion is 22% in all pituitary adenomas, 67% in gain, and 33% in acromegaly secreting pituitary adenoma, and 21% in prolactinomas, and 12% in Cushing's disease. So various grading systems, and Athel-Goel grading system for gained invasive adenoma is a gold standard. Grade 1, confined into the dura, and grade 2, transgression of the medial wall of the cavernous sinus, and grade 3 is an elevation of the superior wall of the cavernous sinus, and grade 4 is a supradiaphragmatic and subarachnoid extension. So the cavernous sinus extension, cytoreduction, and best result should be given along with the gamma knife given. So extended endonasal approaches, these are technique, and surgical steps. So binostril technique, 3-4-hand technique, and dynamic perspective, single cavity, and freedom of movements, wide exposure and wide cellular exposure. All about exposure is important in extended skull-base approach. These are all the steps involving that. The neuronavigation is useful in a early time. ICA injury, optic nerve injury, cavernous sinus injury, once get into it, it's difficult for the total removal. So dural opening, and there are some of the cases. Yeah, just I finish. So these are intraoperative images useful. Intraoperative CM and MRI and intraoperative Doppler is very useful, and ICG also very useful in the picking up of a functioning tumor. So with this, we have a short work, identify the tumor from the normal gland, preservation of the posterior pituitary, but it is not very useful in the above two. The identification of vascular structures and tumor invasion of the dural structures and the functional tumor is very useful in intraoperative ICGs. So the postoperative reconstruction is very important. So with this short thing, so even the continuous advancement in the technology and skill development, the grass-throat resection and most important series of giant and invasive adenomas are not 10%. All phases had a complication in this pituitary tumor surgeries and not predictable. Functional tumors to be removed in total for the best cure. Postoperative endocrinopathies are variable, still not able to predict. Meticulous skull base repair is definitely decrease the CSF leak and its complication, and lumbar drainage is crucially handled and should be very careful to avoid that complication. Thank you.
Okay, thank you. Any questions? I think we'll take it on last at the end. Okay, I will call another, invite another person, delegate, to talk on the challenges and technique in operating on giant vestibular schwannoma, revisiting the sitting position. Anand Sharma.
Good evening, all esteemed colleagues and senior. I am Dr. Anand Sharma, Assistant Professor, Department of Neurosurgery. Today I will be sharing our experience with the sitting position in the surgical management of giant vestibular schwannoma. Vestibular schwannoma more than 4 centimeter size often defined as a giant. They often pose challenges because of their lyse charge. They often compress the brainstem and produce hydrocephalus and involvement of cranial nerves. Always the goal is maximum safe resection, preserve the facial nerve and the lower cranial nerves. These are some pre-operative and the post-operative images where we have excised, that shows that we have excised the tumor completely, and all these cases were done in sitting position. So the question comes, why the sitting position? It improves gravity-assisted drainage, better cerebellar relaxation, clear operative fields, and it lowers down the intracranial pressure that helps in surgical resection of tumor. Some studies claims it helps in complete tumor removal and the preservation of facial nerves. Although it is not without controversies in the concern. Sitting position, the biggest concern is air embolism, and the sum of the study has claimed it is somewhere around 45%. Maximum are clinically insignificant, but in the sum of the cases, it can cause catastrophic effects. Other concerns are cardiopulmonary instability, pneumocephalus, cerebral hypoperfusion. These kind of sitting position requires a good surgeon and anesthetist coordination, and at the sum of the center there is a technical hesitancy, and usually they avoid the sitting position. Institutional readiness is required for management of complications. Although we didn't use the sitting position in all these cases, we have chosen the cases selectively. Cardiac functions were assessed echocardiography, and the pulmonary function tests were used to evaluate the cardio COPDs, and spinal screening was done for cervical instabilities. MRI confirmed the tumor size more than 4 centimeter, and surgeon and the anesthetist team should be familiar with the sitting position. Institute also require proper setup that includes precordial Doppler and transesophageal echocardiography. Central venous catheter is also required for these kind of positions, and patient consent should be there that mention the position along with the possible list of complications. The standard workup for these kind of operating these kind of cases are MRI, brain, angiography. These are the standard workup for management of acoustic schwannoma patients. From the anesthesia side, all the anesthetists should, before giving the anesthesia, there should be proper evaluation of cardiac function, pulmonary functions, and the cervical stability. Intraoperatively, there should be setup that I told earlier, precordial Doppler, and the E2CO2 monitoring is mandatory. Arterial line should be there, and central venous catheter should be there for the aspiration of any air embolism. During the induction, positive pressure ventilation should be avoided. Anesthetist should maintain the normocapnia and normoxium. Balance anesthesia should be given, and low PEEP should be maintained. If there is any fall in E2CO2 intraoperatively, particularly from level of 32 to 24, then anesthetist should immediately inform to the surgeon, and the surgeon should pack the cavity, flush with the saline, and bony margin should be covered with the bone wax. And if it do not come back to the normal level, then surgery should be abandoned and patient should be shifted to ICU, and post-operative CT scan head should be done to rule out any tension pneumocephalus. Sitting position involve flexion at the leg and the hip, and Mayfield should be used. Neck flex in the open flexion is required to open up the CP angle and avoid chin-sternum contacts that reduce the venous return. As far as the intraoperative is concerned, sharp dissection should be done, internal debulking should be started first, facial nerve monitoring should be done, and tumor dissection should be done from the inferior and the medial post first, so that there should be proper space for resection of tumor. Vascular anatomy should be respected, particularly ICA and PICA, and hemostasis should be done without proper packing with the low minimum coagulation. Priority should be on the neurological preservation rather than the complete tumor excision. Residual tumor can be left behind with the facial nerve and the brain stem if it causes harm. And document the intraoperative decision making in the operative notes. We have operated 13 cases in sitting positions, and most of them are on the left side. Sensory neural deficit was the most common complaint, and in the 4 of the cases, there was a slight deterioration in the facial nerve function from grade 2 to grade 3 that improves later on. We have used the shunt preoperatively in 60% of the cases, and we have not noticed any complication, particularly CSF leak, meningitis, any episodes of venous embolism. Gross total resection was achieved in all cases. Mean duration was 4 hours, and hospital stay was 12 days. So we have not noticed any complication of venous embolism. Our results were almost in the same with the other international studies that shows sitting position helps in complete resection and the preservation of facial nerve. To conclude, sitting position is to be associated with both a high rate of complete removal of tumor and improved facial nerve outcome after giant vestibular schwannoma surgery via retrosigmoid approach with zero mortality with low morbidity rate. Thank you.
Thank you. Any questions? Yes, sir. Comment rather.
I need to congratulate you. You have 100% total excision with 100% facial function preservation in giant tumors. I don't think that is ever been duplicated in the literature. Nobody has published till date, to the best of my knowledge, that 100% total excision with 100% facial function preservation in giant tumors. So you should report it, number one. Number two, one of the critical things when you do a semi-sitting position is the foot should be above the neck, right? You showed the diagram, but that is the most critical point. And you give PEEP, you don't avoid PEEP, you give PEEP. This is the only type of surgery where you give PEEP in neurosurgery in tumor. Why you give PEEP? Because you want to increase the intravenous pressure. So that is a bleeding, you can get the veins, you you can pick up the veins. If you do not give PEEP, if you have a low, then you would not pick up, the veins will suck the air, right?
Yes.
So just careful what you are talking about. And please publish it. If you have 100% preservation with 100 total excision in giant tumors, you should publish. I don't think it's reported in the literature.
Thank you, sir.
Thank you. We'll go on to the next paper. Endoscopic endonasal excision of craniopharyngioma, advantages and challenges, by Dr. Pawan Goyal.
Good evening. I'm going to discuss the advantages and challenges of endoscopic approach for craniopharyngiomas. The craniopharyngiomas are although benign tumors, but they are one of the most challenging entities in neurosurgery because they lie close to important neurovascular structures and can cause potential damage to these structures during surgery. The retrochiasmatic location of tumor is best suited for endoscopic approaches for craniopharyngiomas because it gives direct access to the long axis of the tumor and early tumor debulking with minimal manipulation of optic apparatus and can be done, and pituitary injuries can also be avoided through endoscopic approaches. So this is a case example, a retrochiasmatic tumor. We will see the advantages of our endoscopic approach in this video. After initial bony work, we open the dura, and right after the dural opening is done, the cyst fluid is drained. So initial debulking is possible without manipulating any neurovascular structure with this approach. So once the cyst fluid is drained and the dural opening is completed by cutting the intercavernous sinus, so the extracapsular dissection is then done. Initially it started inferiorly, and then we mobilize the tumor from both sides, separating it from carotids. Sharp dissection should be done, and bipolar cautery should be avoided as much as possible. So you can see that tumor can be mobilized without manipulating optic apparatus or any vascular structure. This is the a great advantage of endoscopic approach for craniopharyngiomas, especially in retrochiasmatic tumors. This is the post-op scan. Many studies have shown clear advantage of endoscopic approach over transcranial approach in terms of better gross total resection, better visual restoration, and decreased incidence of recurrence and lesser complications. However, a lot depends on the location of the tumor. The endoscopic approach is best suited for location of tumor in the infradiaphragmatic sellar region. And in this location, it gives best chance of gross total resection and better visual improvement. The tumors which are located more in relation to third ventricle and hypothalamus are not ideal cases for this approach. Because of limited freedom of movement and narrow corridor, there is more risk of hypothalamic injuries in these craniopharyngiomas. Pediatric cases are another challenge for from endonasal perspective because of incompletely pneumatized sinuses, small size of nares and nasal passages, and smaller intercarotid distances. So this is a 4-year-old child with conchal sphenoid sinus. These are the pre-op pictures of the tumor. So as you can see in this video, the normal bony landmarks are not available because of ossified sphenoid sinus. So under navigation guidance, gradually the bone is drilled in the sellar region. Opening is gradually enlarged in the inferior lateral part, and then the tuberculum is drilled. And then the dura is opened in cruciate manner and cyst fluid is drained. And after that, the internal debulking is done. And then the tumor capsule is mobilized from diaphragm and the surrounding neurovascular structures. It should not be pulled without complete mobilization, and then the neurovascular structures are seen after complete tumor removal. Delayed vasospasm was also experienced in one of our cases. It's a rare complication and can happen due to multiple reasons. The cyst content can cause irritation of vessel walls. It can be due to direct arterial trauma, hypothalamic injuries, meningitis, hypovolemia. Even fat packing is reported to cause vasospasm in these cases. This patient responded well to chemical angioplasty and recovered fully. CSF leak is another major complication with endoscopic approach, and this is because of the inherent nature of the approach. And we also experienced 2 cases in which we needed re-exploration for CSF leak repair. We usually pack the cavity with fat, follow it with fascia lata and vascularized flap, and this is further supported with fibrin glue, and we keep lumbar drain for 48 to 72 hours in all of our cases. So to conclude, the endoscopic approach for craniopharyngiomas is best suited for tumors without significant lateral extension, without vascular encasement or multi-compartment location. They are relatively contraindicated for significant peripheral calcification, large solid component, tumors, patients with small sella with narrow intercarotid distance. It is especially useful and superior to any transcranial approach when the lesion is retrochiasmatic with prefixed chiasm. The type 4, that is intraventricular tumors, are actually not feasible with endoscopic approach. Thank you.
Yeah. So you put a lumbar drain in all preoperatively?
Yeah, we place it preoperatively because once the CSF is drained, then it sometimes it becomes difficult to put lumbar drain.
Very right. Nicely done. Thanks. Dr. Mazhar Khan, lateral sitting position, a novel approach for management of pineal tumors.
Hello, good evening respected seniors. I am Dr. Mazhar Khan, working as Assistant Professor Neurosurgery at Grand Government Medical College and JJ Group of Hospitals, Mumbai. I am going to present our institutional experience of management of pineal region tumors in the lateral sitting position which we use. This is our institute. As we know that these are pineal tumors are rare tumors, less than 1% of the intracranial tumors, and they arise from germ cells, spinocytes and stromal cells. They usually present with clinical features of raised intracranial pressure, Perinaud syndrome or cranial nerve palsies or endocrine disturbance. After MRI is the imaging of choice, and once the diagnosis is confirmed and if there is hydrocephalus, after CSF diversion and if the tumor markers are negative, we go for the open biopsy and resection. So these are the various approaches for the open biopsy and resection, out of which the classic supracerebellar infratentorial, the Stein's approach is used in our institute most commonly. These are the position in which this approach can be used. Just now we already seen the advantages of the sitting position by Dr. Sharma sir, and the sitting position can be given in a classic way, or their patient can also be placed in prone position for Stein's approach, or even concord position or 3/4 prone position. MR venography is done preoperatively to identify the location of the deep venous system with relation to the tumor to prevent any damage. In last 19 years, almost 98 cases are operated, and these patients were operated in lateral sitting position with Stein's approach, and follow-up was done with the help of MRI and CT scan. So out of these patients, 60% were male, and most of these patients, 70% patients were less than 40 years of age group. Most patients presented with clinical features of hydrocephalus, for which VPCN was done, and the tissue diagnosis of this patient were pineoblastoma, germ cell tumors, pineocytoma, and epidermoid cyst. And most common complication was pneumocephalus, which was managed conservatively, and in 8 patients, mortality was encountered. This is the position which we give in our OR. The patient is placed first in lateral position, and then slowly head up is given, and then at the end, the Sujita clamp is applied. All the pressure points are taken care of, pneumatic compression device is applied, and preoperatively we take the patient after ruling out any patent foramen ovale, and central line is checked, and neck compression is also checked. Then the classic Stein's approach is taken. The advantages of this procedure is that the surgeon's hands are closer to the surgical field, and with the surgeon's chair, the elbow as well as hands are resting on the armrest. So because of which it becomes comfortable for the surgeon to operate in a long duration of surgery, and there is less fatigue, and you can get a good outcome because of less fatigue. This is some of the cases which I want to demonstrate. This 36-year-old male with headache, blurring, hydrocephalus, classic pineal epidermoid, was given lateral sitting position, and this is the surgical video. Suboccipital craniotomy is done up to the tubercula, and dissection is done in supracerebellar infratentorial corridor carefully till we reach the arachnoid. Arachnoid dissection is done, and then tumor is gradually removed all around with the help of, we do not use any retractors in our surgery. We use a silicone patty over the cerebellum, and then over that the suction as well as the dissectors are kept, which lead to dynamic retraction. It avoids any undue trauma to the brain. So in this way, the gentle dissection is done under microscope with high magnification. All the vessels are preserved, and once the tumor is removed at the end, the capsule is peeled off from the brain parenchyma gradually. You can see the capsule is peeled, and then once the tumor resection is completed, we use the check endoscopy to see all the crevices if any tumor is pending. This is the post-op follow-up of the patient. This is 61-year-old female came with headache, giddiness and imbalance. The pineal region tumor. Patient was done for hydrocephalus. So we use exoscope in this patient in lateral sitting position, as we are trying, as exoscope gives better magnification, visualization, and 3D exoscope has several advantages with the heads-up surgery. But we could not manipulate because the exoscope was coming in the surgeon's view with the operative hands. So we then had to shift the classic microscopic method, and then we continued the surgery with the help of microscope. So here all the veins are preserved with the help of hemopatch. Arachnoid dissection is done. Once the tumor is identified, we use CUSA for the internal decompression. Here we can use the help of, can take the help of CUSA for the internal decompression, and then in the last, once the capsule is identified, it is removed with the help of bipolar, so gentle coagulation, and then watertight duroplasty is done. So this is the patient. In this case, then the next case which we did, then we used the head-up surgery with the help of endoscope, where the assistant was holding the endoscope in the with the left hand and was guiding the surgeon with the. It gives a full end-on view, and the surgeon can manipulate with the help of both hand with the heads-up surgery, like an endoscopic assisted exoscopic surgery. In this way, the entire surgery was completed. I will just rush through. So once with the help of 0-degree endoscope and with the manual scope visualization, the surgeon can tell the assistant to guide in the crevices the scope, and then we can check with the help of 30-degree scope also in all the angles. So this is the pineal parenchymal tumor in lateral sitting position operated. So here we can use a fluorescence. So I will just conclude. So fluorescent dye can be used, sodium fluorescence, to check for the tumor location, and in the same way the slowly, gently dissection is done all around the tumor and the normal brain parenchyma, and at the end check endoscopy is done, third ventricle is visualized. This is the post-op scan. So this case, watertight duroplasty is necessary in all the cases. In this case, the dura was
you can skip
after
this
the
video.
surgery. We use the new dura. So I will conclude.
Yeah, just conclude, please.
So I will conclude. So this is supracerebellar infratentorial approach is the most common approach used for pineal tumor surgery. We use no retractors to prevent tissue damage. Lateral sitting position gives better access to tumor. Position can be, if there is any event of air embolism, position can be immediately changed to the, and the surgeon can also control the bleeding as well as give wash, and anesthetist can manage the embolism. Combined microscopic and endoscopic visualization aids in covering the hidden crevices of the tumor extension and allows complete excision. And full endoscopic or endoscopic assisted exoscopic surgery is also gives better magnification and visualization in these cases. Thank you.
Thank you. This time we'll have a discussion at the end of the last paper of the day. And Dr. Vivek Kankane will be talking on petroclival meningioma.
Good evening, all of you. I am Dr. Vivek Kankane. Today I am present petroclival meningioma, current management and result in 21st century. This study conducted in PD Hinduja Hospital, Mumbai. Petroclival meningioma is considered among the most difficult tumor to be treated by microneurosurgery because of its location and critical structures. We reported a series of patients petroclival meningioma treated in new millennium of goal of gauze total excision or subtotal removal and adjuvant gamma knife radiosurgery. Availability of the stereotactic radiosurgery, which has been associated with excellent tumor growth control and progression-free survival rate with long-term follow-up. So recently, most surgeons have trained to move away from radical resection to preservation of quality of life. This surgery conducted 2001 to 1972 patients. Clinical presentation, operative approaches, complication all are retrospectively analyzed. Post-operative outcome and adjuvant gamma knife and follow-up finding were reviewed. Average age 47.95 years, 52 women and 20 men. Mean duration 66 months, 67 patients presented de novo tumor and 5 have recurrent meningioma. New cranial nerve deficit more common in patients whom total resection was performed. Cranial nerve 8 deficit is most common, followed by cranial nerve 5. 22 patients, 18 subtotal resection and 4 new total resection had received post-operative gamma knife. Only 4 patients had recurrence following gamma knife surgery. This is symptomology. Most common symptoms: headache, diplopia, facial numbness. Total 103 cranial nerves preoperatively involved. After 66 follow-up month, only 20 cranial nerves in deficits. New cranial nerve deficit is more common in gross total resections, and new deficit occur in 14 number of cranial nerves. Average tumor size 3 into 3.2 centimeter, largest 7.68 centimeter. Cavernous sinus extension present in 21 patients. 32 patients had giant tumor greater than 4 centimeter, and 42 patient has large tumor greater than 2 centimeter size. No patient had small tumor. Majority of tumor compressed the brain stem. This is the imaging of all patients be included in a study. Maximum tumor are giant size and large size. There is no small size tumor or maximum involved in brain stem and cavernous sinus extensions. This is a 45-year-old female. Left side, giant petroclival meningioma with brain stem extension. In post-op image, there is a gross total excision, small bit of tumor which attached to brain stem, which leave, and post-operatively, this is clinical photographs of patient. There is no deficit. Operated left side, retrosigmoid supra paracellular approaches. Retrosigmoid craniotomy done. Dura was open when L-shaped, and tumor was debulked in piecemeal fashion, and all cranial nerve try to preserve. Lower tumor removed between lower cranial nerves and 7 and cranial nerves, and try to dissection between arachnoid. Preserved the all diovascular structures. Arachnoid plane was intact. There is a 6, in video there is a 6 and 4th cranial nerves are seen, which was intact. Gross total resection was achieved. This is 4 cranial nerve. Preserved the arachnoid plane. when tumor attached to the brainstem and cavernous sinus extension, advised to subtotal resection followed by gamma knife. When tumor has good subarachnoid plane, to attempt to gross total resection. When plane is not good, then attempt to subtotal resection followed by gamma knife. When elderly patient, advised to osteotactic radius surgery or subtotal resection. When patient is young with cavernous sinus extension, advised to subtotal resection followed by gamma knife. And when tumor extension not in cavernous sinus, attempt to gross total resection. An anatomical location decide which approach we use. When tumor posterior fossa alone and lateral to internal acoustic meatus. In our study, we use the retrosegment approach. When tumor is medial to the internal acoustic meatus and useful hearing, we use the retrosegment approach, canal sparing transpetosal. And not useful hearing, use transpetosal approach. When tumor extend to posterior fossa as well as middle cranial fossa and not useful hearing, we use the combined transpetosal retrosegment orbitozygomate approach. When use useful hearing, then use canal sparing transpetosal. This is also schematic diagram, and this is diagram showing the zone 1, 2, and 3. When tumor associated zone 1, dorsum celli to the upper edge of the internal acoustic meatus, we use the Kawase or anti-petosal approach. When tumor tumor in zone 2, internal acoustic meatus to upper border of the jugular foramen, we use the combined retrosegment or transpetosal approach. When tumor in zone 3, upper border of jugular foramen to foramen magnum, we use the retrosegment or far lateral approach. In our study, maximum retrosegment approach in 49 patients, then transpetosal 9 patients, FTOZ 7 patients. Gross total resection achieved 41.6% of patients, near total 33.3% of patients, and subtotal resection occurred in 25% of the patient. Overall recurrence rate 27.7%. And up to 90-70, only 10 of out 26 patients reported to literature survived the surgery. And parallel advanced myconeurosurgery and introduction of innovative skull approaches late 90-80 led to renewed enthusiasm about radical excision of pitocaval meningioma. So many studies, Sami et al., Almaptis, Smith, Misra, and co-workers et al., there at that time before 90, gross total resection is 7 to 80%. This is the table showing the gross total resection about 85% at the 90-80 study, and 2011 there is a 28% of gross total resection, and there is a minimum mortality and mortality. Total excision rate and series of Sekhar and associates dropped in 78% in 90 and 32% in 2007. Similar in Barrow Neurological Institute and similar in our study. When 125 patients operated 1989 to 2001, 1980 to 2001, there is a radical excision, there is a more mortality and mortality. And after 2001 to 2019, safe resection followed by gamma knife, there is a mortality and mortality also decrease. And Jeffers and associate reported the tumor control rate 94%, patient in skull-based meningioma treated with gamma knife. The conclusion of our study is gross total excision had a best recurrence-free rate with higher morbidity and upfront of gamma knife advisable in patient with residual tumor to reduce recurrence, and flexible approach of individualizing the treatment protocol for given a patient goes a long way toward optimal outcome. Thank you.
Thank you. Any comments from Dr. Mishra? Goel?
So needless to say that surgery on pitocollival meningiomas, surgery on, what I'm saying is needless to say that surgery on pitocollival meningiomas is the pinnacle of neurosurgery. You know, one is the approach to the tumor, how you approach, how you get to the tumor. Second thing is how you remove the tumor. And the third and most important is how you whilst removing how you are safe and away from the dangerous locations. So as one progresses in understanding this tumor, the third part of the story as to how to remain safe is the most critical. Now, as I grow further in this business of pituitary meningiomas, if I have to dissect around the third nerve for more than 5 minutes or 10 minutes, I will not go on dissecting. If I have to dissect around the perforator for more than 2 or 3 or 4 minutes, I will just try to shrug away from that area. So now, as I grow in this business, I will say, of course, I am very radical, there's no question about it. But I don't mind leaving some tumor behind if it comes to. If I'm dissecting the facial nerve for a period of time and trying my skills on the facial nerve, I will not try my skills too much beyond a limit. I think pituitary meningioma is a pinnacle of understanding the subject, your technical skills, your dissection skills, your controlling of bleeding, how you avoid dangers, and how you remain safe.
Okay, thank you, sir.
Thank you. If there are no more questions, we'll conclude the day's proceedings and invite you all to join for grand gala dinner and music. Thank you so much.
Thank you. Thank you, everyone. The gala dinner will start at 7:30 p.m. in the evening. Thank you. Thank you, everyone. The gala dinner will start at 7:30 p.m. in the evening. Here itself.